I guess so. So we're going to push live. So again, I'm going to reintroduce myself. I'm Josh Mailman. I'm the president of NorCal Carcinet in Northern California. I'm also president and board of directors of NetRF, where we fund, as George pointed out, we fund research to help a lot of these innovations go through. I was thinking, you know, Dr. Cherry made a point that, you know, we need patients first, out front instead of behind. And, you know, I was thinking through the various organizations I work with funding nuclear medicine, and we probably, through either NetRF, NorCal Carcinet has actually funded about $150,000 worth of research in nuclear medicine. NetRF has actually funded millions of dollars in nuclear medicine for NETS patients. Even the Education and Research Foundation, when we did our NET tour earlier today, they have funded nearly $1 million in Young Investigator Awards. And it is both our coin, if we have, but also our help in putting these things first for research, so that this doesn't stop and that this doesn't, you know, end here, and that we can continue pressing forward. So it is my pleasure to introduce, we have a very exciting day today, so we're going to go back and forth a little bit. Early on, when I knew we were coming to LA, I asked Lisa if she wanted to work with me to bring people together to come and hear about the advances in nuclear medicine. And she said yes, and here we are. And I'd like to introduce Lisa, who will introduce NCF and a bit of their story, as well as a patient story, before we start our day. So, what do I need to do next? Just don't know with the...
Yeah, please. Hi, everyone. My name is Lisa Yen. I'm the Director of Programs and Outreach for the Neuroendocrine Cancer Foundation. You may know us by many names, and there will be a slide soon. In 2012, we were founded in Los Angeles by our dear friend and NET patient Giovanna Joyce Mbesi as the Los Angeles Carcinoid Neuroendocrine Tumor Society. That's why Josh reached out to us, because we have a strong history here in Los Angeles. So we were known as LACNETS. Most recently, we're taking on the legacy of the oldest neuroendocrine tumor patient advocacy organization, the Carcinoid Cancer Foundation. And we recently rebranded LACNETS. We had a different acronym to it, and now we're the Neuroendocrine Cancer Foundation. So if you see, if you see LACNETS, if you see CCF, if you see neuroendocrine NCF, that's all us. So we're really pleased to collaborate on this important event. My husband was diagnosed with advanced neuroendocrine tumor 11 and a half years ago. And when he was diagnosed back then, there weren't that many options. PRT was a wish. NET1 had closed. We had to travel for it. And now the landscape has changed so much. And we did not know back then that he could survive this long, more than a decade. And look how far the field has come. So he's someone who's benefited from all of this, and we're really grateful. As Josh said, you know, it's about patient first. So we are going to hear a little bit. I think a lot of this stuff can be very technical, and it's very important, but really putting a face on it, hearing a story, hearing how this can make an impact in someone's life, so that this, all the things you're hearing, this isn't the end, right? We don't want to end by getting a great scan, as cool as it is. Sorry, a great, treatment, as cool as that is, right? We want to end XYZ, whatever it is, visiting grandkids, traveling in the mountains, doing the things that we love. That's the reason. It's to live, not to, the end point isn't the scan and the treatments and such. So, that's
Finally,
okay.
just the computer froze.
That's okay.
Sorry.
Hold on. Oh, we're on the patient, sorry. That's okay.
I'm usually going to start with Brett.
That's okay. Not a big deal.
So, we got it working up here. So, can you switch back to this computer? Okay, thank you.
Just really briefly, couple slides. If you haven't heard of Neuroendocrine Cancer Foundation, oh, it's not on. It's okay. We can talk about Brenna. She's more important. You want to talk about Brenna, and then we can come back to the slides.
Sure. Yeah,
Okay. Well, without further ado, let's talk about the more important person. Brenna Bash is someone that we were really honored to meet. She came to our weekly support group during COVID, and we had the fortune and pleasure of getting to know her over the years, watching her through her journey, and she's going to share about her story. Welcome, Brenna. Thank you.
Hello. Hi. I'm Brenna Bash, and I've been living with pancreatic neuroendocrine tumors since 2021. I was a healthy 54-year-old woman, no medical issues, no family history of cancer. During a 2-week period in May of 2021, the universe decided it was going to kick me around a bit. My marriage of 28 years ended. A week later, I was in the ER with discomfort in my abdomen, and the following week, I was diagnosed with stage 4 neuroendocrine tumor cancer. During my ER visit, they discovered a grapefruit-sized mass on the left lobe of my liver. The biopsy showed it was a neuroendocrine tumor, so the doctors knew it was a metastases. Before they could determine a treatment plan, they had to determine where the primary tumor was. So the summer of 2021 was spent trying to find the primary tumor. First stop, endoscopy and colonoscopy. No tumors, just 2 small ulcers. Side note, gratitude to the stress from the ex-husband got me to ER to discover the cancer, so there's next stop, CT scans, PET scan, MRI. They found the primary tumor was located on the head of the pancreas. The treatment plan began. The tumor board determined that I would have a Whipple procedure and a liver resection. Everything was happening so quickly, but I felt confident in my doctor's assessment. Having a major surgery was daunting. I had never had a surgery before, but my surgeon assured me that he was confident in successfully removing the tumors and that I was fortunate enough to be eligible for the Whipple. August 19th, 2021, I have the surgery. All goes well, but they were not able to get all of the cancer from the liver. The tumor board met again and determined that I should begin sandostatin injections right away, not in the future as originally planned. I began octreotide in September of 2021. At the 3-month scan, there was still some growth in the remaining tumors. My oncologist decided it was a good time to introduce PRRT with the goal of shrinking or stopping the growth of the remaining tumors. He believed that the cancer was probably everywhere at this point, but if the PRRT was successful, he believed it could reach the cancer everywhere in my body. It was overwhelming to hear that the oncologist thought the cancer was everywhere. I had been feeling good and had confidence in the doctors and the treatments thus far. But knowing that the cancer was progressing made me feel scared and anxious. In April of 2022, I began PRRT, and I finished in 2022 of October. I had to wait for the 3 months to follow up and see if the PRRT had been effective. I was dealing with a divorce and no spousal support when I received my diagnosis and began treatment. I had to drive all over LA for various appointments and spend 2 weeks in the hospital, all during COVID and being displaced from my home. My 19-year-old twins and a savage group of friends stepped up, drove me, accompanied me, nursed me, and lifted me. I knew I had great friends and kids, but boy, did I learn what superstars I had in my corner. I still can be brought to tears of gratitude. My follow-up scan in January of 2023 was clear. No detectable disease. This was not what was expected, but we are all celebrating. I have had clear scans ever since. I've been fortunate. The treatment plans I've had have been effective. I've had few side effects, and I feel good most days. I only know I have cancer because the doctors tell me I do. I continue living the way I always did before my diagnosis, but I also enjoy each moment with a newfound sense of gratitude. Early on in a support group, I felt guilty because I felt like people in the group were not feeling good. I didn't feel like I had anything to contribute. The social worker reminded me that feeling good today is not a given that I will always feel good, that I should take advantage of those days, get out, move, love, embrace things that bring me joy. I have helped friends with their own cancer treatments, and I have seen how debilitating it can be. I have seen how different things can go. I found love again in 2023. I met the love of my life, and we were planning our future together. Just when life seemed to be getting back on track, he was diagnosed with throat cancer and passed away last year. It has been challenging, but these challenges have strongly reaffirmed my gratitude for the life I have now and the love that continues to surround me. We are all mortal, and I have found that truly understanding this helps me live a better life now. One day when my grief was overwhelming, I had been asking the universe, how do I get through it? How do I move forward? I happened to be talking to a customer service rep who said something that resonated with me. She relayed a story where her mom had told her, "Keep living, Suzette, keep living." This pierced my heart. I knew this message was meant for me. The universe was answering my question. Keep living, Brenna, keep living. Thank you.
Not that one. Now we're going to George Fisher.
Yeah, I know. That's what I'm looking for.
Okay.
Fisher,
Yeah.
where are you? You see it? It's labeled net 101. 101 right there. Fisher.
Net 101, that one.
Feels weird reintroducing someone who's already been introduced, but I will do that. Dr. Fisher and I first met 18 and a half years ago. You've heard that he part of the Stanford Cancer Center and the valuable contributions he's made towards neuroendocrine tumors, neuroendocrine tumor. Don't know what's happening next to me, but that's all right. Neuroendocrine tumor guidelines, neuroendocrine tumor research is somewhat legendary at this point. And it is my pleasure to introduce him and have him give Net Essentials in 20 minutes so that you get a framework of what else is out there before we dive into nuclear medicine and go into the deep end of nuclear medicine for NETs. And with that, my good friend, Dr. Fisher.
Thanks, Josh. Josh can take any 1 minute introduction and make it 10. Thank you, Josh. So 20 minutes is really too short to go through things I ordinarily talk about. This is me upside down, laying on the floor with a camera looking at the bean. I have no conflicts of interest. I mentioned that earlier. This screen's not working, but that's all right. So I don't have a lever there, so I can't leave. But anyway, so starting off with some disclaimers. There's lots of terminology around neuroendocrine that can be very confusing. I'm going to mention that we're not going to talk about anything here, but if any of you have one of these ailments, please contact me afterwards, because I take care of many of these patients as well. But that's not what today's discussion would be. Most of my talks for other physicians and researchers revolve around the different treatments that are available and the data from the clinical trials that got that treatment approved, and then who we think, where we put that treatment in sort of a continuum. Here's one of many algorithms that have been used. This is from a colleague of mine, Pam Kuntz, and one of her graduate students. And so this is one sort of algorithm that can go ahead and not a bad small review that is written mostly in English. Now, each one comes with these questions as to, well, where do you fit in this algorithm and what's the next treatment option? And my point here is to just give you a sense of the magnitude of treatments and why neuroendocrine tumors different from other cancers and why we have such different treatments for it. So instead of going through the details of the specific clinical trials and the drugs, we're going to talk about what makes neuroendocrine tumors unique and how do we take advantage of that. First of all, as everyone knows, we keep talking about it as a zebra, as if it's very rare. The incidence is low, but the prevalence is high compared with other cancers. In fact, this is an old slide, but the prevalence of neuroendocrine tumors, meaning the number of people who are in the community with a neuroendocrine tumor diagnosis, is much higher than the number of people diagnosed with stomach cancer and pancreas cancer. The reason is very simple. The people with stomach cancer and pancreas cancer will die within a number of years. The people with neuroendocrine tumor are still alive. So even though the incidence is low, the number of new diagnoses per year is low, the prevalence of people who have this disease throughout our community is relatively high compared with other cancers. So tell the drug companies that. I tried to tell the drug companies that 30 years ago. They didn't believe me. Now they're actually courting you, so that's good. Now, even though the incidence is low, it's actually increasing. So this is a slide that Dr. Desari from MD Anderson put together. And you can see on the yellow line that the incidence of neuroendocrine tumors is going up relative to the overall incidence of cancer, which is relatively flat, thankfully. But this is not an epidemic. I don't want anyone fearful from that. This is primarily because of increased number of diagnoses, not increased number of cancers. Meaning that during the same time frame, from the 90s on, we started doing many more endoscopies, many more colonoscopies. Most gastroenterologists would do a colonoscopy looking for a polyp that was a centimeter or greater, but they will pick out nowadays 3 and 4 millimeter things in the rectum and make a diagnosis of a neuroendocrine tumor. Those are really inconsequential, but they go into the registry. Same with CT scans. You heard wonderful talks about imaging this morning. The fact that if you eat a bad burrito and go to the emergency room because you have stomach pain, you're bound to get a CT scan while you're in the emergency room. And so incidental diagnoses of cancer are also going up. And that person might have lived an entire life not knowing that they had a neuroendocrine tumor, or they might have developed symptoms 3, 4, or 5 years later. So it's good to have an early diagnosis, but that's really an incidental finding. So I don't think that there's a real pandemic of neuroendocrine tumors. It's just that we're finding more of them these days. And one example of that is if you look at the top of the yellow line, it goes down. It went down in 2019 because we stopped doing colonoscopies and endoscopies because of COVID. So it's not down because it was decreased number of people with the disease. We just stopped looking for them. So net nomenclature I mentioned is difficult. Just ignore everything on the left side. It's confusing. Sometimes even the word carcinoid. We've tried to get away from the word carcinoid. It's still with us, but really what we want to focus on is the right side, which is site of origin when we know it. And as Bernard said, that sometimes we don't know it right from the start. So it sometimes takes a little bit of work to find the site of origin. Degree of differentiation. How ugly does it look under the microscope? The uglier the tumor looks on the microscope, the more poorly differentiated it looks, the more poorly behaved it's likely to be. This is not a pathology talk, but pathologists will look at tumor architecture under the microscope, and if the tumor is trying to emulate the tissue of origin, so if a breast cancer looks like normal breast tissue or trying to look like normal breast tissue, that means it's well differentiated. Its genes are still trying to pretend that it's from normal tissue. If it has nothing to look like the tissue of origin, it's very scattered, cells different shapes, they're not really lining up in glandular elements or anything like that, then that's poorly differentiated. Those tumors tend to have a little bit more aggressive phenotype, and that's what pathologists do. So pathologists give us a guess as to how they think the tumor will behave based on differentiation. For neuroendocrine tumors, we have Ki-67 staining. People have heard of that. That's basically a molecule in cell surface that pathologists can bind to. Turns out that Ki-67 staining is a crude surrogate for cells that are capable or soon to divide. So it's almost like looking at the number of cells that are dividing. And so we use that as part of the grading system for a neuroendocrine tumor. The other way we classify neuroendocrine tumors is by function. And the endocrinologists and we in oncology have arguments back and forth about what's a functional tumor. If you have a clinical syndrome that's associated with a secreted hormone from your neuroendocrine tumor, we call that functional. But you have to have a clinical syndrome. And the dispute is that endocrinologists feel that if you have that hormone floating in your blood, you have a functional tumor. But if that hormone, from our perspective, if that hormone's not doing anything to you, we don't care. Okay? So we might use it as a tumor marker, but if it's not causing flushing, it's not causing diarrhea, it's not causing any number of other things, it's a non-functional tumor. And of course, we want to know, crudely, are there metastases or not? So one description that we teach our fellows to say, well, this is a pancreatic primary, well differentiated, the degree of differentiation, well behaved is another way of explaining that. Grade 1, which is the best of the well behaved. Non-functional, meaning that they're not having diarrhea or anything associated with hormone. Neuroendocrine tumor with liver metastasis. That tells this whole story. So the net nuances that impact therapeutic opportunities include the slower growth, as we have already mentioned. The fact that the tumor grows slowly means that you'd like to have a surgeon who's experienced with that kind of tumor. So Eric Liu here is a surgeon who does neuroendocrine tumors. If you went to a surgeon that's a general surgeon or a surgeon that does pancreatic adenocarcinoma, they might look at something and say, well, I can't remove that. And they could be right, but neuroendocrine tumors are the one type of cancer that you can debulk or you can remove 95% of. For an adenocarcinoma, if we can't remove 100% of it, we don't go in at all. Because by the time the person recovers from the surgery, what 5% of tumor is left will be growing. So the fact that things grow so slowly allows us the concept of debulking. If it took 5 years to go from a golf ball to a volleyball, we could take out the volleyball, leave a couple marbles behind, and maybe it'd be another 5 years before you need to have another surgery. So surgery can, even if it's not curative, can buy quality time, and that can happen with neuroendocrine tumors more so than other cancers. Fewer mutations. So lots of cancers have lots of mutations. This is not a talk about genes, but we also sadly know that the immunotherapy that you see advertised at football games and television all the time, all these great advances in immunotherapy, which are truly spectacular, have not been applied to neuroendocrine tumors. largely because there aren't enough foreign-looking things in the neuroendocrine tumor for the immune system to attack. Now, there are other reasons too, but the tumors that have the most mutations are the ones that are most sensitive to the immunotherapy drugs. Neuroendocrine tumors are among the least mutated tumors that we see. Oftentimes, these tumors would start in the gut or the pancreas, will go to the liver, and only in the liver. We don't see them anywhere else. Yes, they can be hiding in other places, but that's why the PET scans are so helpful. But if you only see them in the liver, say, well, why don't we just focus on the liver? So you can, and oftentimes people do, have liver metastasis resections or ablations, very common treatment for these tumors, and rarely it's even appropriate to consider a liver transplant if you have cancer only in the liver and no place else. So that's still controversial, but it's still done periodically. I think I've recommended it to 8 or 9 people now over 30 years, so it's not very, very common. Also, these tumors have a unique aspect in that they have greater than normal arterial blood supply. So you know that the arteries feed oxygen to the tissues and the veins take the blood away to go back to the lungs to get more oxygen. Their arterial blood supply for neuroendocrine tumors can be fairly higher than the normal tissue that they arise from. Hence, treatments can be delivered through the arteries with greater effectiveness, and some of our best treatments are drugs that block blood vessel formation and presumably help keep the blood vessels from feeding the tumor. So anti-angiogenesis agents or drugs that inhibit blood vessel formation is another option. I don't have it on the list here only because this is a huge theragnostics meeting with thousands of people and researchers. Not that researchers aren't people, most of them are. But I'm not going to go into that at all, but one of the other wonderful things about neuroendocrine tumors is most of them have the somatostatin receptor, and we can take advantage of that not only for PRRT, but eventually, we hope, for immunotherapy, using different immunotherapy treatments that can then target cells that have the SSTR2 receptor. So this is an ugly slide. The top 2 images are neuroendocrine tumors from the pancreas. On the left, you can see these large, probably 5-6 centimeter lumps, so softball size lumps in the tumor. On the right, top right, you see multiple 2-3 centimeter spots occupying the entirety of the liver. Even though they're the same stage, liver metastasis, the one on the left, Eric would say, well, I can take that out. And he's nodding, yes. The one on the right, I wouldn't even send Eric because there's no way that he'd be able to attack that. So the one on the right is mine for systemic treatments, whether it's PRRT, chemotherapy, or even octreotide type treatments. The one on the left, we would have a surgeon involved. We would have an interventional radiologist who's going to speak later today. We'd have a nuclear medicine doctor. We'd all congregate together in a tumor board and discuss who has the best tricks for this person and how should we sequence those options. On the bottom, just for comparison, those are metastases from a colon cancer and a pancreas cancer. They're dark compared with the normal liver. The top ones are bright compared with the normal liver. So again, we can take the therapeutic advantage by putting drugs or putting attacking through the artery, which can just go right here through vessels down here by your leg, thread that catheter up. Instead of going all the way up to your heart, which everyone knows that's what catheters can do these days, and they can put little stents in cardiac vessels like that. Instead of going that far, before you get to the heart, you take a left turn, and you're in the liver. And once in the liver, you can advance it to those spots that you see on the top left there and squirt bad things at it. You can squirt little beads coated with radiation. You can squirt chemotherapy. You can even just squirt things that will block the blood vessel and keep that tumor from growing. So those are called transarterial treatments. Transarterial chemoembolization or transarterial radioembolization would be perfectly fine for the top left, not at all for the top right.
It's a right turn, by the way.
It depends on whether you're standing at the feet or the eyes. And don't listen to Dr. Liu here. So a well-differentiated grade 1 non-functional, both these tumors really have the same volume of disease, but very different treatment options. And that's points out the importance of a multidisciplinary tumor board, because the interventional radiologist will have one trick, Eric will have a different trick, I have different treatments, the nuclear medicine will have PRT, and we put that all together to come up with the best treatment for that patient for that time. Now, you heard a lot about scans. I'm not going to delve in that, but not all CT scans are created equal. If you go to a community hospital, again, with a stomach ache, and you get a scan, it's usually a venous phase scan, not an arterial phase scan. And they usually don't do a non-contrast scan, but they'll just go ahead and do a venous phase scan. If in the middle here, I think you can see, maybe you can't. In the middle, you can see something, again, the size of maybe a softball. That white spot in the middle in the liver is a tumor, a neuroendocrine tumor, an arterial phase scan. It's arterial phase because, again, I don't think that this is working here. Arterial phase scan, the aorta is bright white. And so Eric and I know what the arterial phase scan is, and that allows the tumor to light up like a light bulb. 30 seconds later, that tumor, the blush of the contrast goes away. And so if you look at the bottom left scan, that's a venous phase scan. I don't see anything there. Now, a radiologist might have a better eye and pick out something, but I don't see anything on the scan. That's the same patient, the same day, minutes apart. So the arterial phase scan is important for neuroendocrine tumors on CT scan. The venous phase scan is sometimes deceiving and you can't see it. I think that more and more the field is moving towards MRIs, and what you heard of it, of course, is the PET scans, the dotate PET scans. On the left is an MRI with EOVIST. It turns everything that's normal in the liver white, anything that's not a liver cell is black, including blood vessels, cysts, and tumors. So you can see those three little spots on the top left that I have a yellow circle around. Those are each neuroendocrine tumors, and you can tell that because if you look to the right, the same patient, the same little spots light up on the dotate scan. So those are 4 and 5 millimeters that I can measure on the MRI, and I know that they're neuroendocrine tumors because the dotate scan is positive. Now, I don't want to get into a wrestling match with my nuclear medicine specialists, but I don't think that, for me, I don't care how bright it is, as long as it's not growing. So I like the MRI to tell me that it's not growing. And if it starts to grow, then I know I have to treat it. But if it just stays stable and it's bright like that on the right, I'm happy to watch it. So the nuclear medicine scans tell me what's cancer and what's not. They don't necessarily tell me whether it's growing or not, because it's like looking at the sun, the brightness of the sun. And I hope that I'll get corrected here fairly soon when they get a chance to speak. So this is all about prognostication. Pathologists and radiologists and nuclear medicine specialists try to give us a sense of how that tumor will behave. I told you about the pathologist with a Ki-67 and the degree of differentiation. The nuclear medicine folks will look and they'll say, well, if it's positive on an FDG scan, that's a metabolic scan, and negative on the somatostatin scan or the dotate scan, that's a bad tumor. And I would probably agree with that, because it's not trying to pretend it has like a neuroendocrine tumor. It's de-differentiated and it's metabolically very active. If it's positive on the dotate scan and negative on the FDG scan, that's probably a better behaved tumor, and it gives us opportunity to treat with somatostatin receptor targeted therapies. If it's positive on both, that's not always bad, but it's probably a little bit worse than the FDG negative scans. So we can use the nuclear medicine as another way of getting a sense of how will this tumor behave. But none of our prognosticators beat the power of observation. The most important measure for me is time and tumor growth. So if you have the ability to watch a tumor, you can have the ability to decide how aggressive is it behaving, and therefore how aggressive a treatment does it need. I think that Sometimes, if you're not sure, but you have a bulky tumor, you have a lot of tumor in the liver, or you have a large tumor that's causing symptoms in the pancreas or the abdomen, so symptomatic bulky disease, or you have a tumor that's causing lots of a syndrome, secretory syndrome like carcinoid tumor and carcinoid syndrome, you know you have to treat it early. So you don't have time to watch it. You have to go ahead and start treatment and take your best guess as to what the right treatment would be. That's where those algorithms can come in, because it gives you some different options for tumors that you have to treat right away. Conversely, and this is important, if you have small volume metastases that are not symptomatic at all, you can sometimes just watch them. Have them come back in a few months and get a scan. Sometimes they're nervous about watching. Sometimes you can say, well, maybe we'll just do octreotide. But then once you do octreotide for that person, you're basically committing them to octreotide for life, because we don't know when to stop octreotide. Okay? So a shot in the butt's pretty easy compared with lots of other cancer treatments, but do you really want a shot in the butt the rest of every month for the rest of your life if you could avoid it? So the importance of multidisciplinary tumor boards, expertise from each discipline focused on neuroendocrine tumors and their nuances. So this is really important. I think that tumor boards are essential for neuroendocrine tumors. And I tell this from friends. I have a friend who's a surgeon that Eric knows, who's kind of a truck driver type guy, and he says, yeah, well, this guy came into my clinic with an unresectable tumor, so I took it out. So my point is that there are different surgeons with different levels of expertise and different levels of willingness to go ahead and try to remove cancer. And for neuroendocrine tumors, again, you don't always have to remove all of it. You can remove 95% if it's causing a problem or if you think it's going to cause a problem. And I'll let Eric comment on that when he has the podium. So especially in the context of a tumor board where the surgeon says, well, I think I can get this if you can make this spot a little bit smaller. And so, okay, maybe we'll work on making that spot a little bit smaller with some mild chemotherapy or some PRT or some ablative technique or external beam radiation. We can work together to try to make this person a better surgical candidate so that we have a better chance of helping that person recover from a safe and effective surgery. The preoperative treatment and the whole strategy that we put together is important to coordinate all the various disciplines. So it's oftentimes the medical oncologist who's, I think of as the coach, the surgeons think they're the coach, the nuclear medicine folks. So lots of cooks. So I'm going to just close with one case. This is the 3 slides I showed you, and I just put down some different ways that a tumor board might think about the different options for each one of these. And I'm not going to go through the options because that's too much detail for the different therapeutic treatments. And everything I said here applies not only to pancreatic neuroendocrine, but G1, G2, other neuroendocrine tumors. But I want to close with this case. This is a woman who came to me after having some belly pain, went to a local emergency room, had a CT scan, guess what, venous phase CT scan, which detected a tumor in the head of the pancreas. So she went to surgery, she had a Whipple surgery, her tumor was removed. The surgeon came in and said, well, good news, it's a neuroendocrine tumor, you don't need anything else. She came to Stanford just a month later. She was just married. A month later, and she came to me and I said, well, I looked at the scan, it's a venous phase scan, let's get an MRI. We got the MRI on the left. Then we got a dotatate scan on the right. And she panicked because she thought all these were new. I always tell people before I get these scans that said, if we see something, it doesn't mean it's new and growing. It could have been there before, we just didn't see it. So I reassured her that these are small spots, asymptomatic, too many spots to send a surgeon right now, but let's just go ahead and think about treatments. And we talked about PRT, we talked about temozolomide, we talked about octreotide, lanreotide. She said, I really want to have kids. I said, okay, come on back in 2 months, we'll get another scan. 2 months, the scan looks the same. So she had a kid. These are the different treatments that we talked about. Any of them could have been reasonably applied. Recently married, would like to have kids. I repeat an MRI, no difference. She has a first child. I wait until baby's born, got another MRI, no difference. August 2012 to November 2025, 13 years, and no difference. I've never treated her. I could have been giving her octreotide shots in her butt for 13 years, every month, and taking credit for stability of disease. But this is how the disease can behave. Now, this is unusual, I fully admit. My point is that we have all these treatments. We don't need to rush in and give each and every treatment. We can kind of pause, assess the biology of the disease, and then decide what's best for the patient. So with that, I think I'm over time. I'll leave you for questions, or if there are time for questions later, I'm happy to do that. Okay, questions later. Thank you.
Good afternoon again. It's my pleasure. I'm going to do this really quickly. Dr. Lisa Bodai, we're having a meet the author session. There are abstracts that are submitted. I think there were over 1,000 abstracts submitted at this particular Congress, and several of them were on NETs. We picked 2 out for presentation rather than going downstairs to meet the author. Our author is a very well-known nuclear medicine net specialist, Dr. Lisa Bodai from Memorial Sloan Kettering. And I think you were selected to present this as well to the general audience downstairs as well. So not only did we pick it as one of the things we wanted to see at the NET patient session, the SNMMI picked it as something to see for their Meet the Author session. So without further ado, I will introduce a very good friend, Dr. Bodai.
Well, thanks, Josh, and thank you all. Such a pleasure and an honor to present here our results of the phase 1 study of a new form of PRRT, a type of PRRT that I called enhanced PRRT. So let's dive into, and I hope I can be as clear as possible, and please do let me know if something is not clear. So, as Dr. Fisher has very nicely portrayed the place that PRRT occupies in the care of neuroendocrine tumors. Our mainstay for the treatment with radioisotopes of neuroendocrine tumors is the approved drug, which is lutetium dotatate. For neuroendocrine tumors, we know it's effective. It has, however, limitations. We know that the drug leaves the body very quickly. We call this clearance, and a lot of radiation is wasted. Only a minor fraction of the radiation that we give to our patients actually reaches the tumor. So we're trying to find ways to improve the amount of radiation that goes to the tumor and gets internalized, gets taken inside the tumor cells. And we're trying to do this while trying not to increase the dose of radiation to the normal organs. We're always trying to maintain a good trade-off. So the idea is to help the drug stay in the body longer. And here you see how the principle is the same of the Lutathera, so we give a drug that is linked to an isotope and reaches the body, the tumors, and then delivers the radiation inside. And we have this motto: we see what we treat what we see. We need to thank Dr. Baum for this motto, because these are your words. We can image, we can treat and re-image to assess the response. So what is the rationale? How do we keep this drug in the circulation much longer? We link this drug to a sort of hook that binds a protein that is in the blood that is called albumin. You probably know the name from your lab tests: the total protein, albumin, and so on and so forth. So that's albumin, is the principal protein of the blood. And if we hook dotatate to this protein, we keep it longer, so in the blood, and the drug has more time to be delivered at the tumor site. So that's what we do. So this drug was experimented by us in a phase 1 study. So that's the type of study where we want to understand how safe it is and what's the maximum activity that can be delivered and what's the optimal activity amount of drug that should be delivered. So based upon studies that were previously conducted in China, we decided to, this was the protocol that was developed in agreement with a company. The treatment was divided in two cycles, not 4 like the classic lutetium dotatate. The schema was the same, treatment, lab work, another treatment, lab work, and assessment of response. We decided to divide the patients in dose levels or activity levels. So that's the design that we obtained. So, and we decided to do dosimetry. What is dosimetry? It's that if you see, this is the sequence. We prepared the patient, we injected our radioisotope, and we took images. Lutetium can be imaged. We took images, and we saw how the image is modified over time. We took also blood samples, and based upon how the drug disappears from the body, we can calculate the amount of radiations that go into the tumors and the normal organs. So that's what we did. And we also considered the amount of radiation that went into organs like the kidneys or the bone marrow as our limiting factor. So we had embedded in the protocol that if these thresholds were exceeded, we would have adjusted the amount of delivered activity for the second cycle. So we enrolled 6 patients with inoperable, heavily pretreated gastroenteropancreatic neuroendocrine tumors. We had actually 4 pancreatic and 2 ileal neuroendocrine tumors. Grades were all 2 and 3, no G1, all with high, intense somatostatin receptor expression at dotatate PET. And as you can see, patients had received multiple treatments. And safety was our primary aim, so we noted that the treatment was generally well tolerated. There were only mild adverse events such as nausea, fatigue, and mild alopecia, just like with normal garden variety dotatate. No renal toxicity was observed, and the last patient was treated already 2 years ago, and we had no renal toxicity. We had some hematological toxicity. This was in part expected. We had a grade 3 febrile neutropenia, which means that this patient had a lowering of their blood circulating leukocytes, white blood cells, and developed an infection for a few hours, obviously, as a cause of that. And this was observed at the level of activity of 100 millicuries, or 3.7 gigabecquerel. At the same time, we had another parallel study that was run in China, conducting the same kind of analysis, and they also noted the same event at 100 millicuries. So in agreement with the sponsor, we decided to call 100 millicuries the dose-limiting toxicity, and we decided that the 50 millicuries would be a better option for a future phase 2 study. So the dosimetry basically, so the analysis of how much radiation goes into the tumor reflects what we just said. So the kidneys and the spleen receives the highest dose of radiation. The median kidney dose was that number, 4.8 grays per cycle, higher than what we observed with standard PRT, but again, we didn't observe any toxicity so far. And regarding the tumor uptake, this is also a nice thing. As you can see, those are the serial images that we collected over time. And as you can see, as we move along with time, there is the drug clears from all the unnecessary sites of the body and progressively accumulates more and more and more where the tumors are. And actually, the top right figure shows that if we measure the amount of drug at 24 hours and the amount of drug at 169 hours, the drug is, accumulates in a higher fashion after a little, some time. So that was obviously encouraging prolonged tumor retention, increasing uptake over time. And when we calculated the tumor dose, there's obviously variability. No one patient is equal to the other. No one lesion is equal to the other. But the doses were obviously encouraging. And in terms of efficacy, we had 1 partial response, 5 stable disease, 2 patients progressed 6 months after the treatment. As I said, the phase 2 recommended dosage was 50 millicuries. And so in conclusion, compared with standard PRRT, 2 cycles of lutetium dotaebittate resulted in a great radiation dose to both tumors and organs. Dosimetry guided our administrations and helped us preventing toxicity, despite the fact that we had a higher irradiation of the kidneys. Bone marrow received radiation beyond what conventional dosimetry model anticipated due to the strong binding of the agent to the SH2R positive tissues. We had some hematological side effect, and so we established the marrow as the dose-limiting organ. Our take-home message is that this kind of enhanced PRRT is a potentially viable high uptake substitute for conventional PRRT because it is carried out in 2 cycles, which means that in a few months, in 3-4 months, we can have an answer whether the treatment was efficacious or not. So it's a viable condensed 2-cycle protocol that may enable an earlier evaluation of the treatment response. Obviously, we need more studies to optimize and study better the potentiality of this drug. And with this, I thank you all for your attention. Happy to take any questions.
Control of the machine up here, so that's why we have AV coming and switching slides on us all the time. It will come up there in a second. Our second paper talks about gallium-68 and U-177 dotatate as well in GEP-NET. So Dr. Lin is from, if I remember correctly, the NIH, right? The NIH. So yet another NIH speaker, and we're pleasure to have you present your poster.
Thank you. Thanks. It's an honor to be here, and thank the committee for selecting my abstract and give us a chance to talk to you. So for those of you who don't know me, I work at the NIH, so I'm a nuclear medicine and medical oncologist by training. I work primarily with somatostatin-positive tumors, so and PRT is my area of research. So, okay. So a lot of this has been covered, but there's a lot of different options for gap-dense spread. But I'll just be talking about one aspect of the PRT, which is the Lutathera, of course. And then you heard a little bit about dosimetry from Dr. Bodai. So what my abstract is about is one way to try and make the dosimetry easier and primarily easier for patients to do, because there's some challenges to doing dosimetry that I'll talk about. So for background, PRT, as we all know, is a radiation-based kind of treatment. So it makes intuitive sense that the amount of radiation that you can give to the tumor is one of the major determinants of how that tumor will respond to the treatment. So it's something that for PRT has not quite been definitively established, although there's more data coming out to support that. But of course, being able to predict the dose before you give the PRT would have a lot of advantages in terms of treatment planning, prognostication, and so forth. So many of you may be familiar with external beam radiation. A lot of the data on PRT in terms of radiation dose comes from external beam radiation. Of course, for external beam radiation, the way that's given is you have a machine outside the body that generates the X-ray beam. That gets turned on, you shine the beam on the tumor. And then from that, by using a computer to kind of collimate or weaken the beam, you could actually design the beam pattern to give certain amounts of doses to the tumor. And for external beam, it's something that can be pretty accurately determined. So you could draw a treatment planning graph like that will tell you exactly, once the beam gets turned on, how much radiation dose does the tumor and other parts of the body surrounding tissue gets. So for external beam radiation, the dosimetry, it's pretty worked out, it's part of standard practice, and it's a well-known aspect of treatment planning. Now for PRT, it's a little bit different because PRT is given in the body, it circulates, so biology plays a much bigger and more unpredictable part of the dose determination. So there's all different factors. For instance, the different concentration of the somatostatin receptor on each tumor could be different. Even factors like blood flow to the tumor, that'll determine how much the drug gets to the tumor. The total tumor burden, because you have a lot of other tumors, more high percentage of the drug could go to other tumors when you look at one particular tumor. Factors such as clearance, how well your liver and your kidney works, that determines how quickly the body gets rid of your drug and how long the drug stays in the body. The movement of the drug itself over time, it could flow from one part to the other, maybe it gets inside the cell, some of it gets out of the tumor. But all that collectively we call pharmacokinetics, or the biodistribution of the drug after it's given to injected into the body. So for PRT, the process to determine dosimetry, like I said, it's a lot more complicated. It's usually done after we give the drug, like the Lutathera or some sort of surrogate, and then we acquire images that image the drug itself, and then usually a nuclear medicine physician with some assistance from software program, we go in and draw regions around each of the tumors. Like you can see in the picture there, there's a lot of different color circles. Each of those, someone went in and actually drew a region around it. And once you have those regions drawn, that you can measure how much radiation activity, how many counts in each region. So that region is called an ROI, region of interest. And then you repeat that process 3 or 4 different times, and then you kind of add up all the counts, you do some mathematical modeling, and from that, you can get an estimation of how much dose a tumor is getting from your dose of the PRT. But there's some problems with that. One is very consuming for the patient. Each of those scans typically takes about 30, 45 minutes to take. So you have to do that 3 to 4 different times. And usually it's spaced apart over maybe 3 days, 4 days. So it's a lot of trips back to the hospital. Not to mention each time it's at least probably an hour time commitment. For the physician, it's also time consuming because they have to go and draw. You can imagine, some patients, there might be a lot of tumors, 50 different tumors. That would take a long time to draw. And then, so there's also a question of resocialization. It takes up the camera time and so forth. So for our project, our research question is, can the DOTA PET scan that pretty much everybody gets before the PRT, can we use that to predict the dose, the absorbed dose or AD that will be given to a particular tumor? So what we did is that we used the DOTA scan that was obtained at baseline, and also we got another DOTA scan after 2 cycles of the PRT, so mid-course. It's a 3 time point dosimetry scan. We scan after 4 hours, 24, and 48 hours after each dose of the Lutathera. And then we want to see what imaging parameters on that baseline scan best correlates with the absorbed dose that's eventually calculated. So just as an example, you see here on the left the DOTA PET scan, and then on the right are 3 of those post-treatment dosimetry scans, usually done on gamma camera specs. So you can see the distribution where the tumor lights up. It's similar to what the baseline DOTA PET scan shows. There's some differences which reflects with the passage of time, the Lutathera going to different places, but that's why we need those 3 time points at least. So, there's a pretty busy slide, but generally, what this is trying to show is that you do see a correlation with some of the parameters, especially the SUV mean and the SUV max, that for each tumor on the baseline DOTA scan. And that correlates well with how much dose that particular tumor gets eventually. So on the graph there, on the x-axis, the horizontal is the imaging parameter, and then the y-axis is the dose. So you see there's a good positive slanted line upward. So there is good correlation between the parameter and the dose. And then just showing it graphically, each of the different colored bars is a different imaging parameter that we looked at. So the purple and the deep blue are the SUV and the SUV mean, but we also looked at other parameters. One's called the MTV, one's just basically the volume. And this is just showing that the SUV mean and max, does correlate the most with the eventual absorbed dose. And then similarly for the midterm, the mid-treatment PET, we're able to show that PET correlates with the dose calculated from on cycle 3, which would be the dose of the PRT that you get right after that scan. And then similarly, there's a graph. So what this all means is that you could use that baseline PET. It would simplify the process of doing dosimetry in a predictive and maybe prognostic use. It might be a way where we could more easily perform dosimetry and get that information instead of going the current method, which is the 3 or 4 different scans after each treatment. So in a nutshell, that's what the project is about. And of course, this is a fairly small study, so we need larger studies to confirm these findings, standard disclosures. So I'd be happy to take any questions.
Thank you, Dr. Lin. I think what this really kind of supports is that, even though we have released drugs and released imaging and all these things, we're continuing to study them. we're continuing to try to understand how to better use the tools we already have, and that, we need, these are all small research things, but we need them in order to keep advancing the art forward, and that the art is being advanced forward. So now a change of pace. We're in I would say normally I would introduce Dr. Eric Liu as a surgeon, which he is, and quite a good one at that. But one of the initiatives that he's done over the last year is about optimizing health. When we're going through all these treatments, how do we optimize our health as we do that have nothing related to the treatment necessarily? So what I'd like to do is introduce our good friend, I think most of you know him, Dr. Eric Liu, to talk about optimizing your health during your treatment journey or during your cancer journey. And at the same time, I want to let you know that he's catching a flight because he's starting a new clinic tomorrow morning. And so when we take our 10-minute break after that, if you have questions for Dr. Liu, come talk to him directly so that we can get it out of, not get it out of the way, but so you can get your questions answered before he catches a flight. And with that, Dr. Liu.
Thank you, sir. All right, friends. Well, God, I can't believe I'm going to do this in this room because it is freezing in here. But since we're all neuroendocrine people here, I'll show you the t-shirt I wore for you guys. Oh, look at that. We're zebra people, right? No, I know, right? Oh, no, it's too cold to go any farther than that, yeah. Oh, what's that? I know, I need a sweatshirt. That's exactly right. Well, this is so much fun to be with you all, and it's always great to talk about neuroendocrine. So I just want to start. There are actually some very interesting people in this room right now. I mean, you guys are all super, the most important part, but I don't think you guys can appreciate like how important Dr. Fisher really is, right? He really was yeah, for sure. He really is a pioneer and a hero, and he's been incredibly supportive of me and our Healing Net Foundation for many years. But the best part is every time I do a talk with Dr. Fisher, I always say, so Dr. Fisher, please tell me, who developed gallium dotatate in the United States? No, come on, Justin.
Take a bow.
Say it.
Take a bow.
Vanderbilt, and you.
That's right. But the most interesting thing is the first time I ever did a presentation on gallium dotatate in the United States was at his meeting, Dr. Baum's meeting in Germany. That's right. He had the gall to invite some poor 30-year-old kid all the way to Weimar, Germany in Bad Berka to talk about our first experience of gallium dotatate in the, it was the first World Gallium Congress or whatever you call it. That's right, 2011 is when we first started all this. And so you have in this room some people who have dedicated their whole lives and careers to taking care of you all and developing the tools that it takes to take care of you. Because I'll bet a bunch of you have had dotatate scans, right? And PRT. And these are the people who have developed all these things for us. So it's really quite exciting. Okay. And fun, and it's always great to be with friends. And so my job, I have clearly transcended my abilities now because Josh no longer brings me to talk about surgery. He brings me to talk about wellness, which is fantastic. It's much better and more interesting, if you ask me. But as you all know, let's just make sure everyone knows, the first therapy for neuroendocrine tumors is to always, that's right, cut it out, that's right. Does anyone know what the second line of therapy is for neuroendocrine tumors? That's right, you gotta cut it out. Josh has seen this slide before. And the third line of therapy, Dr. Baum, is what? That's right, it is not PRT. You gotta go and you gotta cut that stuff out. So, the problem with Dr. Baum and Dr. Fisher is they can only see your body through machines. That's not how I do things, right? This is old-fashioned stuff. So you see, so this is very similar to the tumors that he showed on the CAT scan. You see that's the liver. Those are the retractors pulling back the body. And and see that ball? That is a neuroendocrine tumor. Wow. That is a neuroendocrine tumor, right? It's about this big. And, this patient, what's that? No, it's real. Yeah. 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 There's nothing to this. And just as Dr. Fisher said, she was told it could not be removed. So I removed it, right? See the divot? Do you see a drop of blood? Not a drop of blood. And watch this. Oh, look at this. Wait, I'm not even done. Watch this. Hold on. Oh, look at that. Look at that samurai sword. Right. So the question is, would you rather have that in your body or out of your body? Right? Clearly you want it out of your body. How much do you weigh? Oh, probably like almost almost 1,000 grams, like a kilogram-ish, something like that, a little more than that, maybe 1.2, somewhere in that range. It changes because what happens is it's like you cut it and all the blood comes out of it. And so, but anyway, it's big. You don't have to, I don't do anything here. So I know I was here to try and talk about kind of wellness, and the issue about that is impossible. You can literally have a whole conference about wellness, and we probably should do more. But the kind of cool thing is that they've been doing more research into this, which is actually really fantastic. Just last year, or early this year, I can't remember, George, they did a study about people who had colon cancer and just the importance of doing exercise. And people who did exercise lived better and longer. The reason it took so long to do the trial was because it took a long time to recruit patients into it. But the results were really quite clear. And if you see at the bottom, sorry, it's a little fuzzy, it says here, they had 3-year structured exercise program led to significantly longer disease-free survival. I mean, it was almost as good as giving some kind of a chemo for a long period of time. And then if you look at sleep, right, so sleep duration with cancer patients, you can see if you slept enough, you actually got a pretty good survival. What we found out is if you slept too much, that was probably a bad sign. You probably were not well and you had to sleep all the time, you had no energy, so that was not good. But right in that kind of 6, 7, 8 hour range is exactly where we wanted. And it's very important. Now, the problem is if you do a literature search on cancer and nutrition, you will find 28,000 papers. So that means people have spent time writing 28,000 papers, and still we don't talk about it enough. We don't talk about it enough. So in my mind, I think the important thing is to really talk about it, and that's what's so critical. And you can see here, again, I don't need to tell you this, right? Nutrition is important, it improves survival, all these things are important. In fact, some people would argue, like for pancreas cancer, right, which is the deadliest and most horrifying of them all, if you can just take care of them intensively in a nutritional aspect, they will live longer, and it's almost as good as some of our chemotherapies, right, except they'll live better. Because that pancreas cancer syndrome is something that can be really quite deadly. That's what people die of, right? People ask me all the time, well, what do people die of? Well, they can die of complications of the disease, but a lot of the time it just has to do with nutrition. And people are just doing very poorly, getting weaker and weaker, and that's what happens. All right, so here we go. This is the kind of feast that I would produce for you if you ever wanted to come to my house. I can feed you all these kinds of things. This is Dr. Lou's feast. So this is why nutrition is so important. You can see there's sourdough bread here at the bottom, homemade sourdough bread. Anyone who follows me on social media knows I'm big into that. And I always make my own coffee every single day, every morning, freshly ground, no plastics, anything else. A lot of protein inside here, of veggies. You can see fish. I even made paella once. I was so proud of that. But that's not really, like I told you, there's no way I can cover all those things. And so what I really want to just spend a few minutes on is thinking about something a little bit more philosophical, which has been touched on already throughout the beginning portion of this talk, which was you heard Lisa and you heard Brenda talk about living, right? Living life. You heard Dr. Fisher talk about time, right? He said, because what he said was the only test that works all the time is the test of time. Every other scan we do, every other pathology test we do, they're all trying to predict and be a surrogate for the test of time. And that is the most critical thing. So those are the things. So I'm going to ask you kind of to do one thing for me. I just want you to kind of open your mind and let me reframe the way that we think about some of these things. Because, what I do is extremely technical, obviously, right? And what is being presented here, or even presented just a couple minutes ago, is extremely technical. But what is not technical is kind of you guys, right? It's about your lives and how you live and the things that you do and what does that mean. And so all I want is to reframe the way that we think about this and maybe even reprioritize the way we think about it. Because it is important to have new molecules. Gosh, it's important to have whole body scanners. That's amazing. But again, the purpose is to get you to the mountain so that you can be with your loved ones and you can enjoy the smell of the flowers that come out in the spring in the Rocky Mountains, which is really quite special. So the question I would want you to think is not purely, not just how do I not die from the disease? And I'm not saying that's not important, right? But that's my job, right? Your job is to show up. You show up, you get your blood test done, you get your surgery done, you get your, your shots or whatever it is, you get your scans. So your purpose now is, the question is like, how do you live life with this disease, right? Because I work super, super hard for you to be able to go to the next wedding or the next birth of a grandchild or the next birth of a niece or a nephew or whatever it is that you guys want to do, or another birthday. That's all it really is. And sometimes I have to make the decision, well, in fact, we should maybe not do treatment, right? Because your life will be better if we do nothing, right? Sometimes that is the right thing to do, but that's a hard decision to make. Dr. Fisher gave you an amazing example of that, an amazing example. And I learned that actually from him and from other of our colleagues. So here's what you can do, all right? So the acronym I came up with is called SEES. So these are the only 4 things you can do as a human being, and any human being. You can sleep well, you can eat well, you can exercise well, and you can have good spirits. Okay, those are the only 4 things that you can do as a human being, right? Now, if you come from Germany, spirits may have a different definition. But it means what is coming from here, what is coming from your heart, what is coming from your mind, what is the life you want to live. Because these are the differences, right? Sometimes, and I know this, right? I'm sure Brenna can just tell us, when she got first diagnosed, it was overwhelming, I'm sure, right? It just felt like life all of a sudden was about to end and it was racing past you. When in fact, it doesn't have to be like that. It can be more like what Dr. Fisher presented, which is like, we have a little time, let's take a deep breath. At least you have neuroendocrine and not something crazy like, pancreatic adenocarcinoma. So let's just figure that out. And then the other thing too is, as we all know, someone said this, I think Lisa said this, we are all mortal, right? The only thing that you will do is you will die and pay taxes in California, right? I've already done that. But the goal is always to push that down as far away as possible, right? It's coming. I'm sorry. It is coming for all of us. But if we can push it away as far as possible, then that's my job. And for neuroendocrine tumor, the beautiful thing about it is it's like a wide open highway. You can just kind of keep, as long as I keep kind of you going straight, it's okay. If you have lung cancer, it's like driving on the edge of a mountain with no brakes on. I mean, if you take one misturn, you will fall off of the cliff. So my goal as a neuroendocrine doctor is to just kind of keep you going straight and keep you going straight as much as I possibly can. You veer left, you veer right, you can probably get away with it. But we still have to keep moving forward, right? And so what I tell people all the time, so this is the way you have to think about this. In fact, I was just talking to Kathleen about this, right? So if you have a certain amount of cancer, right, the up and down arrow, and that is the amount that will kill you, over the amount of time, right? And so the blue line is the amount of time that, the good Lord has given you on this earth. You now have to think about, like, what are you going to do with that time, okay? So it's actually it's the time that's terrible. So if you have a lot of cancer and it gets worse and worse and worse, you will die of the disease. The disease will kill you, right? But if you can kind of do all the things you need to do your medicines, do your treatments, live well, you may die with the disease and not of the disease. Does that make sense? Those are two very, very different things, right? And sure, this happens. I'm not saying it doesn't. I'm not perfect by any means, right? I've tried to take care of people, and I've tried to, always try to save their lives, but they will die in my hands. There's no question. And even if it's really close and they're 80 years old and they can still die of their disease, that still happens. But sometimes we have people who have lived wonderful lives and they're well cared for, and they're 79 years old, and they had a stroke, and they died in their sleep, and they died with their disease. That means I've done my job, right, as an oncologic person. And sometimes people, just like Dr. Fisher presented, have very, very small amounts of disease. And they just go about their lives and just die of something else. And that is the goal, right? So the question is, how do you do that, right? How do you do that? And for me, I always say it's much, much easier to keep you healthy than to dig you out of the ditch, right? I'm the one who frequently has to dig someone out of a ditch, right? They have some big tumor that's blocking them. They're bleeding from their stomach all the time. Their liver is congested with tumors, and I have to pluck those things out like you saw, right? So, and then I put them farther in the ditch because I've now just traumatized them. I have sliced them in half, right? And then they have to heal from that. So none of that is fun. None of it's helpful. None of it's fun, but it is helpful in the long term, right? So you have to think of it that way. So yes, you might take a hit, but then I can keep you healthier in the long term. So what I'd rather do is this, kind of keep going, but sometimes if doesn't go so well, you will fall in the ditch. And that can be from many things. That can be from malnutrition. It can be from not managing your pain. People develop something called carcinoid heart disease, in which their valves break and their blood flows backwards. You can have just good old-fashioned weakness. And Dr. Fisher, what is always the chief complaint of every neuroendocrine patient? Every time? Fatigue. It is always fatigue. Is it flushing? Probably not. Is it diarrhea? Sometimes, but usually not. It is universally fatigue. And so the question is, how do we make that better? Well, in my opinion, it's actually much better to just keep you up here if we possibly can. So that means you've got to see your healthcare professionals, right? You've got to show up. You've got to follow the treatments, hopefully, that we have devised for you as NET specialists to take care of you. You need to eat well, right? A lot of times, I hate to say this, the oncologists say you need to eat more protein. Right? Anyone heard that before? Oh, just eat more protein. I mean, what does that mean? That doesn't mean anything, right? So you need to eat well, but that means you've got to eat well probably under the guidance of a trained nutritionist who knows these kinds of things. And for those of you who aren't aware, neuroendocrine nutrition is not the same as regular cancer nutrition, right? Those are all incredibly important. I need you to exercise. I need you to get up. I need you to move. That is one of the few things that we have absolutely demonstrated that improves longevity, improves health, and improves all those things. So you've got to keep moving. And then sleeping. The one thing that's been demonstrated to reduce your lifespan are people who don't sleep well, right? Because that's the time that your body heals. So I have to tell my nurses at nighttime, just please don't bother Mrs. Jones. She just had surgery. Just let her sleep through the night, right? Anyone experience that? Getting woken up 4 times at night, right, because of that? And then most importantly, I just want you to enjoy your time, right? So we have a community here, just right here, that we've put together. I have a wonderful community of colleagues and friends that I get to work with. And those are the things that are really important. Like, I'm not with my family right now because I want to be with you and be with my friends. And that's meaningful to me. So the 2 words I always say is you need to live with the time that you have. And that's it. It's very simple in many, many ways, right? So people are always asking me, they ask me these technical questions like, well, what if I do this, and what if I do this, and what if I do this? And I tell people all the time, that is my job, right? I trained a very long time, and I'm very good at what I do to decide those things for you. That is not your job. Your job is just to think about how do you live, how do you sleep well, how do you eat well, and how do you get to spend more time with the people that you love, right? And these are things we've heard for decades and decades. These, if not centuries, these are deep philosophical things. But it doesn't mean that you can't have a good care team that understands your disease, what treatments you're going to be taking, finding a support group like this or on social media. Those are all unbelievably important as well, too, because you just don't want to feel alone. When you were first diagnosed, how isolated did you feel, right? It's real. And then you find the community and you find people and you find, hey, I'm not so alone. I can do this. I can do this. Brenda told us about her family and her children and how supportive they were, right? So if you really, really, really want details, do me a favor. Here's your QR code, okay? Take your phone, take a picture of it right now, right? And so this is the real lecture that probably Josh wanted me to give, but it takes 8 hours. So I'm not going to give the 8-hour QR code, right? But just take a quick peek of it. All right, everyone got it? Got it? Okay. So, oh, sorry. Go. Come on, let's go. Do you need more shots? Is that what's going on? Go with this. Don't worry about it. I think Karen got it. It's okay. We're okay. Yeah. So this will take you to the Healing Net Foundation SEAS page, right? SEAS is sleep, eating, exercise, and spirits. We had 4 programs in Colorado just last year to kick it off, but it was so well received and so important. We're actually doing multiple programs now across the United States. But more importantly, we videoed all of them for you guys. So if you want to learn about sleeping and nutrition and exercise and physical therapy and sleep, feel free to go to the website and just click on all the videos. I think there are probably like 6 or 7 hours worth of videos, if not more, of videos on there, which you can just kind of listen to and enjoy. And again, a little bit to like what Dr. Sherry said, there are a lot of people who are behind you. So these are pictures, which I'm very, very proud of all of the Healing Net Foundation summit meetings that we've had. We just had one in Tampa just a month ago. And you can see several of the people here in this room are actually in the pictures here, which is really great. And so all these people, again, have dedicated their lives so that you all can live, well and live better lives. And just remember that we're here to support you, and there are people here to support you, and there's a whole community to support you. But let me do my job, and you do your job. All right, friends, that's all I got. So now it is time for a break, right? Yes, we have a 10-minute break. Everyone try to warm up a little bit. We'll see you in a few. Yeah.
I would say we're in for the last stretch. And so hopefully you stretch your legs after seeing what we should do with exercise. And Dr. Lewin sees what? He's trying to herd cats. All good. I figure I start talking, we herd cats. So as you find your seats, I realize that the printed agenda outside does not necessarily reflect what we're doing inside. So on the website, the actual current agenda is there. And now we're really going to get into the kind of final rounds of what we're going to do. We're going to talk about interventional radiology, followed by the difference in practices between the US and Europe and kind of recent history, and then followed by what's available in the US with, and then really G3 and beyond. Where are we going? We will then have time for Q&A. So the speakers that are left, and I know some of them are going to have to fly and go, but we'll be here to answer some Q&As that have been accumulating in the chats, and have you all have a chance to ask questions in person. And then there is actually a reception right after. So there's yet more food, maybe a warmer room. And we'll go forward from there. So it's my pleasure to introduce Dr. Gabriel Fine from the City of Hope in Duarte. Many of you have gone to the City of Hope. He has a specific focus on theranostics and nuclear medicine. And he's going to talk about interventional radiology in NET treatment. With that, the floor is yours.
Thank you so much, Josh. It's really a tremendous honor to be here. When Lisa and Josh invited me, I was really incredibly touched to get to speak to all of you. I'm fortunate to be part of the NET community, and I've worked with so many of the physicians here. And I've also worked with many of the patients, have been to many support group meetings, and have been tremendously lucky to get to know you guys on your journey and to be part of that journey. I'm kind of in its own way, a zebra on my own, in that not that I have neuroendocrine tumor that I know of, but I'm a diagnostic radiologist and interventional radiologist, and I'm a nuclear radiologist as well. So kind of blend a variety of treatments along your journey and pathway. These are just some disclosures. So I was asked to speak about IR today, and when it comes to IR, oftentimes IR is looking at the liver, not especially when it comes to neuroendocrine tumor. Now, if I were to ask many of you in the room, how many of you have liver metastases, I'm guessing many would be raising their hands, and I see some that are. You can see it's up to 90%. So the majority of you at some point along your journey are going to have liver metastases. And having those metastases, that often defines your prognosis. So you can have tumors throughout your body. Having these liver metastases is tremendously important to be treated. 80 to 90% at the time that you present with liver metastases, they're inoperable. So we just had Eric Liu speak, who cuts it out, which is tremendously important, and we value everything Eric does along your journey, and the multidisciplinary team is important. Many times, these lesions are inoperable. So this is just one sort of classification system of neuroendocrine liver metastases. So you have type 1, type 2, and type 3. Type 1, single metastasis of any size. Type 2 is isolated metastatic bulk accompanied by smaller deposits within both lobes, always involved. And type 3 is disseminated, so metastatic spread, both lobes, always involved. And this sort of classification system can sort of help us determine which route sometimes you may go. In terms of type 1, if there's a single metastasis, you can really aim to try and get rid of it all. I mean, that would be ideal, and when it's possible, you want to do that. Oftentimes, as the bulk increases, we have to move towards other liver-directed therapies, potentially systemic therapies, and especially as disease moves outside of the liver. So when it comes to local disease, this is one area that sometimes we can do within interventional radiology, where we really can sometimes aim for cure. You know, in general, living with neuroendocrine tumor, it's a lifelong journey, and you're going to be living with it. But if there is just one site and it's small enough, we can aim for cure. There's a wide range of different ablative technologies. The idea is very similar in that you kill that tumor. And there's a variety of ways. In red, you can see this RFA microwave ablation and this laser thermal ablation sort of system. So that's the red side. Cryoablation, which actually is a cooling, or it's like trying to freeze that tumor. IRE is actually called irreversible electroporation. It causes sort of these breaks in the cell membrane. And then there's also HIFU and histotripsy that actually use ultrasound to try and break up the cell membrane. This is just one example. The tools that we have in radiology and medicine and interventional radiology just are constantly growing, and I think this is really something very exciting for all of us, for patients, for physicians, for everyone in terms of what we can do. And in this particular image here, we have on the top, and I know George was mentioning earlier, the arterially enhanced image. This is an arterially enhanced image. You can see the aorta in the center there, bright white, and there's this little tumor. And generally speaking, with ablations, you aim for fairly small tumors, especially when they're 3 centimeters or less. You can really aim to hopefully get the whole thing. And so this tumor, it's kind of hard to read, but that tumor is less than 2 centimeters, so it would fall in that range. On the bottom, we have this ultrasound tool. Ultrasound, you can image that tumor, and this one is Doppler, so you can see where the vessels are. And so you can really guide your needle to that tumor and try to make sure that you're avoiding those important structures. In the upper, let's see if I can grab the arrow cursor here. It doesn't appear to show up. This upper CT image is post-ablation. So actually, I'm going to actually skip down to the bottom ultrasound image there, where you have the probe in that tumor, and you can actually see it becoming more white. Do you see that? Do you see how there's sort of this black area around? I wish maybe this cursor works. I can't get the cursor to work, but there's sort of this line that goes to the tumor, and then you see this sort of white ball. That's that ball cooking. So you can actually watch it cook in real time under ultrasound. And on the top, you see that hyperdense, so that's the more white tumor in the left hepatic lobe, and around it you have this rim, this hypodense rim. That's the ablation zone. So you have an idea that you've cooked that tumor, and yet you're sparing much of the normal liver. So it's very exciting that we can actually target these tumors minimally invasively, and in some cases, maybe in the future, without even doing percutaneous punctures at all. And we can actually see and just treat that tumor and preserve much of the normal liver. So in interventional radiology, there's actually a wide range of paths that I would say IRs play an important role in. We kind of focused on one path where you've got one lesion and you treat that and kill it, but there's a wide range, and actually many of you in the room will kind of face all these different paths at some point along your journey. There's one where you have low burden, no symptoms, the volume is low, and you can maybe just observe. You can continue to observe, you live life. Our goal, as Eric mentioned earlier, is to have all of us, me, all of you included, enjoying and living life, making the most out of each and every day. Path B things progress. You become symptomatic, the volume may have risen some, and then sometimes you start a medical management. You could do sandostatin, some somatostatin analogs. And I know I'm speaking to many of you who have gone on this journey, so you all know this very, very well. Past C, a high burden, so you have more than 25% volume, abnormal liver function tests. This is a time that oftentimes you wind up seeing that interventional radiologist and you start considering liver-directed therapy. And that can be a handful of things. Sometimes it's the surgeon that can still cut it out, right? Eric said that that's very important, and by all means that still is a gold standard should it be a viable option at the time. But other things such as ablation and embolization can really be considered. And then there's another path. And this path comes down to what you're going to hear so much about today, which includes theranostics in terms of systemic therapies, in terms of when we decide, you know what, this is beyond the liver, the growth is really outside the liver. How can we help live life and still make that determination for what's best for our patients? And I would say IR plays a role in all 4 of these pathways. So this is one of the reasons that intra-arterial therapy is so beneficial. And I put down medical illustration generated by Google Gemini because that illustration was. I was going to show you a liver of the multiple circulations, and I decided, you know what, I'm going to try to use AI. And it did a pretty good job. It did a lot of things better than, or faster than I could, but this liver, those that are in the medical field would know that this is not a viable patient because the aorta and the IVC are connected. And I tried to change this for a very long time, but I gave up because it illustrates much of the important points. And the important points for you, don't ever try to make your aorta and IVC do this. It's not a good idea. But what I wanted to point out was this dual supply of the liver. So in the blue, you have the portal vein, and it supplies 75% of normal liver parenchyma. So the majority of the liver is supplied by this portal vein. And to IR's benefit, and why one of the reasons we can do so much in terms of helping fight your cancers, is many of the tumors are supplied by the hepatic arteries. So in red are the hepatic arteries, and those are supplying the tumor, yet much of the liver can still be alive because that portal vein, that big blue vessel, is supplying much of the liver. And so the idea is we can go selectively into that artery, deliver some sort of therapy or embolic agent, take out that artery that's supplying that tumor will die and necrose, and your normal liver can still survive. And that's really one of the concepts that have made this possible. So when would we treat the hepatic metastases? I've got that very anatomically incorrect liver again. But we do it for symptomatic and it's not controlled by medical management, where things are getting worse in some way. So your LFTs, your liver function tests may be going down. Sometimes the tumor bulk is just greater than 25% of the liver, occasionally for neoadjuvant purposes. So maybe it's possible to shrink these tumors prior to resection, and oftentimes progression of disease. And one thing that we have to always consider is what is your tumor grade. So some of you are here with a very, very slow grade 1 tumor, a very slow growing tumor. That may dictate how quickly and how aggressive we have to be versus a grade 3 that's growing quite rapidly. And so those are things that we have to consider too as we decide when do we intervene, because we want to try to make the best decision that will allow you to live and enjoy life as long as possible. And we know that we're not going to cure this disease, but we're going to try and keep you enjoying every day as long as we can. And for many, that can be an incredibly long time. And I look at many of you in the room, and I've seen many of you over the years, and I see you guys enjoying life. And to me, that's just a tremendous gift that we all have to appreciate. So these are benefits. The embolization can be quite beneficial, excuse me. Symptom control, the response rate is 85%. Disease debulking can be 55 to 60% of cases. Typically lasts about 18 months. The localized progression, the progression occurs most frequently in the liver, so it's quite often that you guys will come back for embolization at many, many times. And again, liver is the primary organ at risk. So the liver, when we see the disease really progress dramatically, that can be a big problem. So being able to do these embolizations, keep it under control, can allow you to keep on living life and keep enjoying it. There's a low rate of mortality, and the severe toxicity is generally quite low. So this is just a very, very brief sort of overview of different embolization types. There's transarterial embolization, which is basically what we also term as bland embolization. And this is purely trying to cause ischemia. So you deliver these beads into that vessel, and that vessel's starved of what it needs, and it just sort of dies because it needs the blood, it needs the oxygen to live. Chemoembolization, you take the catheter, deliver both the beads as well as chemotherapy with it. And the idea in this case is causing that ischemia, but also local delivery of chemotherapy. And then radioembolization is an infusion of Y90 microspheres. This is actually local radiation. If you think of like brachytherapy for patients that may have prostate cancer, where you insert these little seeds, this is like giving a whole ton of those. But you give it directly to the source, and that radiation over time will kill that tumor. So which one should you do? And there's a lot that we just don't know. You know, I'd say in many respects, a lot of people will choose bland embolization to just cause that ischemia. Many will choose chemoembolization. In certain circumstances, people will do radioembolization. Radioembolization is highly, highly effective. One thing which is wonderful about neuroendocrine tumor patients is you guys live a long time, hopefully. And obviously everyone, there's a range, and there's a range for all of us in life. But there are some fears that cirrhosis or challenges with radioembolization in certain circumstances can be a problem, but sometimes it can work quite well too. And this is still being investigated, but there's a trial that Mike Sulin, who many of you guys I think probably know because he's been very active in the neuroendocrine community, who did the RETNet trial. He looked at comparing transarterial embolization, which is bland, TACE, which is the chemoembolization. He also was originally looking at DEB-TACE, which I didn't talk about because, quite frankly, it's determined that DEB-TACE does have a serious adverse event rate. So, and that's where the chemotherapy is actually in the bead itself. So you deliver the bead, and that drug is eluting from the bead itself. And by and large, what the RETNet trial showed, at least the most critical, is DEB-TACE probably should be avoided in patients with neuroendocrine liver metastases. In terms of bland embolization versus TACE, there are differences between the two, but largely depending on the expertise and your physician's comfort and their experience, either have their benefits and are strong considerations. This is just one example from the literature where Y90 radiation segmentectomy, it kind of functions like ablation in its own way, where you go very, very localized to that tumor. And in this sort of circumstance, it may very well be a great option. Because Y90, it's that radiation, and it can kill that tumor a little bit further than the ischemic part, probably. And that's because it's radiation killing it and not solely ischemia. So in this first image, you can see that arrow showing the one lesion. The catheter in B here, you can see it's actually injecting this contrast, and the tumor itself is taking up that contrast. So that very vessel is leading to that tumor, and it's telling the interventional radiologist, this is a good place to deliver the therapy because the majority is going to go to that tumor. The next image is just sort of what can be done in interventional radiology is while you are asleep on that table, you can actually get an image of the liver after you've injected this contrast to confirm, yes, this is going where you expected. The image below, number D, is actually this area lit up where that Y90 went, and you can see the majority of the liver is just not touched. But that spot has all this radiation, and that final image on the right is this area that's now dead. And you can see the arrow is showing this black area. So the tumor right there is being killed, but the majority of the liver looks great. So in this sort of circumstance, Y90 probably is not hurting the majority of the liver. It's hurting the part we want it to. And so in certain circumstances, Y90, even for patients that are going to live very long, may also have a very, very important role. I mentioned that IR is important on 4 paths, and that was a very simplified thing. We only have 20 minutes. But one path is also determining when should we go to systemic therapy? When should we not do this local regional delivery? And these images are actually from a patient that I was fortunate to get to help take care of. We are part of a multidisciplinary team, and I'm going to show you a couple more images of this. But this patient came and saw me and also saw one of the oncologists that I got to work with extremely closely with. And she had an interesting course. She had started PRT. She had gotten 2 doses, and she got those 2 doses before she saw me. And she actually, believe it or not, first saw me at a support group and came and talked to me, and we wound up seeing her, and I talked to her about her history. And she didn't know what to do, because at the time of her original diagnosis is her maximum intensity projection image of her PET, where you can see very few lesions. And then at the time she talked to me, this is what her maximum intensity projection image looks like on the other side. And you can see she had widespread disease. She had disease really, really quite profoundly, and she had already done 2 doses. She couldn't continue due to thrombocytopenia. Her platelets were too low. So we met with her, we redrew labs, and her platelets had improved. And this is 2 years later, so this is quite a bit later, and she had been told she's done with PRT. But because her platelets had improved, we wanted to make sure, is PRT the right choice? So we also got what's called an FDG PET-CT. FDG PET-CT will look at the sugar, the amount of sugar the tumors take up. Typically, well-differentiated tumors are tumors that have the SSTR2 expression, that somatostatin receptor expression, most commonly have more uptake on the dotatate and not FDG. I hope even those of you in the back can tell that there's more uptake on the dotatate, the one that I wrote dotatate on there. You can also see these fused images. Her tumors were extremely high on the dotatate PET-CT, and we said, you know what, let's give you another chance. Let's go back. I can't tell you, will your platelets do well, but right now they're doing well enough, we're gonna try it. And we did. And so we tried it, and thrombocytopenia returned. She also had bilious vomiting, fatigue, bad stomach ache, and we've postponed her treatment again. But her platelets ultimately improved to 92,000, and she got her final dose 3.5 months later. Remember, the intensity of her uptake was profound. I don't have the numbers, but they were profound. And I just have her pre-cycle 3 treatment, so before we saw it, just focus on the liver. Those are all spots, right? All those tumors, many of you probably have seen, maybe some of you even have livers that look like this. And post-cycle 4 is down below. It was almost gone. And if I showed you her bones, very, very similar. She had a profound response. She was told that not to continue because of thrombocytopenia, but she didn't give up. And as a team, and it wasn't just me, it was medical oncology, our team, we didn't give up either. I've moved to California recently, but after I moved, I saw her and she was living life. And so I think it's a profound sort of message to all of us that we're in this fight together. And so just to summarize, IR is the cornerstone of the multidisciplinary team. We bridge the gap to local control and systemic therapy. It's essential in navigating progression of disease, determining when to treat locally and also to transition to systemic care. We are at a time of tremendous innovation. You know, I'm so lucky to be here with all of you and with many people that really led the field. You know, I'm excited to see what the future will hold, and I'm very optimistic. This is the other AI picture that I had at Google Gemini. I said I was giving a talk to patient education for neuroendocrine tumor, giving me a zebra. It gave me this one with a very short white coat. Somehow it had sort of City of Hope colors, but I thought that was kind of cute. And this is the City of Hope fountain, and you can see, you know, I think it's really meaningful in that you have, I view this as sort of a family and a little child, but everyone's together, and we are together in this. And then this picture, I messaged Linda and told her that I wasn't going to get the slides in quite when she wanted it, in large part because of this picture in the center. This is my 8-year-old son's baseball team. They won their neighborhood Little League championship last night. Now, there's more to the story, though. And one of the big things is they were not even close to the top seed. They were number 7. Number 7 out of, there were more than 7, but not many more than 7 teams. But they functioned as a team. They were a team. They lived life. It was tremendously fun for me. Just as I hope you all are able to go out there and have many tremendous days of fun. And they were a team. And we're a team, and I feel tremendously honored to be part of it with all of you and to get to know you and to get to see you guys out enjoying life. So thank you very much.
So I want to bring Lisa back up just for a short presentation of overview of theranostics in U.S. versus and Europe, given that she is practiced in both places. And we often have this concept that things are better in one place versus the other. And although I haven't seen her presentation yet, my guess is there are challenges in both places to which to overcome. And I look forward, oh yeah, it's up there. I just saw, I look forward to this presentation. Thank you very much, Lisa. And thank you for sticking around.
Thank you. Well, let me just say that differences nowadays are getting thinner and thinner, so maybe I could just finish here. But let me say a few words. Thank you again. It's thanks, Josh, and thanks, everyone, for inviting me. So how do I advance here? Just a clicker? Okay. Disclosure. And let's start with the theranostics paradigm. I don't know, was it introduced already today, theranostics concept?
Yeah.
It was. Okay, so I'll be very quick. It's a mixture of diagnostic and therapeutic techniques so that we can use the same drug for imaging and therapy. And the goal is to obviously optimize our treatment. We can, as we said before, we can see and treat what we see, and we can do diagnosis, therapeutic procedures, and then follow up the patients. So theranostics are not new. They started in the 1940s with radioactive iodine. We went a long way, but finally we have the lutetium dotatate approved in Europe, and then in the USA in 2018 for neuroendocrine tumors. 2022 Pluvicto, so lutetium PSMA, was approved for metastatic castration-resistant prostate cancer in the USA by the FDA and in Europe by the EMA. Today we have over 400 clinical trials, actually more than 500, exploring new theranostic agents. The approved theranostic treatments today and how they work. So these are the two approved treatments, lutetium dotatate and lutetium PSMA 617, one for neuroendocrine tumors, the other one for metastatic castration-resistant prostate cancer. The mechanism of action is the internalization, which is the fact that the drug is transported inside the tumor cells where the radioactivity is released and where the lethal effect of radiation can be exerted on the DNA of the cell. Theranostics became popular with landmark studies two studies were conducted in neuroendocrine tumors, the NERO-1, the NERO-2 study that demonstrated in midgut carcinoids or neuroendocrine tumors and in G2, high G2 and G3 neuroendocrine tumors demonstrated a superiority of lutetium dotatate over standard of care with high-dose somatostatin analogs on top of the landmark curve of the progression-free survival for the patients who were treated with lutetium dotatate compared to standard of care. For prostate cancer, the VISION trial and the PSMA-4 trial established lutetium PSMA as a standard of care based upon the improvement of the progression-free and overall survival, and basically granted the approval of this drug in 2022. So this is the core of what I have to say. So what is the similarity? What are the similarities and the differences? So both drugs, lutetium dotatate and lutetium PSMA 617, are approved for treatment in Europe and in the USA by the different regulatory agencies. Both drugs require a confirmation of the target expression before the treatment with PET. There are joint guidelines. We have joint guidelines with between the SNMMI and the European Association of Nuclear Medicine to standardize treatment and delivery. What's different? Differences are getting slimmer and slimmer, but Europe pioneered early academic theranostic use, starting from the Netherlands, Germany, and Italy, and Switzerland, has to be said. What is different is that in the USA there is a scalability, there is an infrastructure that allows for expansion and for a tremendous scalability of the theranostics that is probably not attainable in Europe, aside from Germany, which will be illustrated by Professor Baum. And Germany is in a very fortunate situation of creativity and legislation. Access, regulatory timelines, EMA approved Lutathera slightly before FDA, probably not great. Of difference, access and reimbursement obviously varies by country. In Europe, most countries have a national health service. In America, obviously, we have insurance coverage, and this has been evolving from allowing only certain categories of neuroendocrine tumors, for example, to be reimbursed. Nowadays, we have, thanks to the lobbying activity of our society, thanks to the NCCN guidelines, we have extension, and you can tell me, but we don't have denials anymore for lung neuroendocrine tumors, we don't have denials for paragangliomas, for pheochromocytomas, and we don't have denials in most cases for retreatments with PRRT. Supply chain might be a problem in terms of scalability, but our radiochemists and the government are working to help us out. In terms of guidelines, this was the first guideline that was produced. Richard, we were together in this action back in the 2009 to 2011. We produced the first document that represented a convergence of everybody who was doing PRT, and we agreed on a document, and it became the joint International Agency of Atomic Energy, European Association of Nuclear Medicine, and SNMMI practical guidance. And nowadays we have a new version, update 2026, where we gave indications regarding the differences across country, Europe and USA. The main difference, for example, is that in the USA, we can only do what is FDA approved. Anything else has to be administered through a clinical protocol, whereas this is true for most of European countries, but apart from the fortunate Germany, who has the exception on the compassionate use law that allows them to be able to treat patients in a better manner sometimes. So what does the treatment look like for patients? The same. We have a treatment administration. We have treatment schedule. Lutathera is 4 cycles. Pluvicto or lutetium PSMA is administered in up to 6 cycles. Usually patients tolerate radiopharmaceutical therapy better than chemotherapy. Common side effects for these treatments are fatigue, nausea, low blood counts. Rarely we have kidney effects, as we discussed before, bone marrow suppression, but most patients go home on the same day, that's the US, or the next day in Europe, but I know that the legislation is changing in Europe. In Italy, for example, which is my home country, my original country, they are working on providing lutetium PSMA therapy on a single day hospital and sending them home on the same day. So obviously Europe is trying to provide the access to these treatments, and a long hospitalization usually doesn't fit with access very much. Future of theranostics, obviously this will be dealt with by Professor Baum, but just a few hints. We have a lot of new targets, some of whom are also valuable in neuroendocrine tumors. We have new radionuclides that we can use, the alpha emitters, the much potent, like lead-212, actinium-225, terbium. New strategies, move treatments earlier, combine treatments with immunotherapy, chemotherapy, or DNA damage inhibitors, the so-called PARP inhibitors like olaparib, personalized dosing, and you have also other cancer types which are being included in the theranostic treatments, not just neuroendocrine tumors and prostate cancer, but also brain cancer, renal cancer, lung, breast, and so on. Just to give you a few hints, there are currently more than 500 trials underway in the world, more than 75 assets being experimented in clinical trials, more than 20 cancer types. Obviously, there is ongoing innovation in radioisotopes and targeting molecules, and this means that there is an exponentially growing market value, which is obviously the result of what we do every day. Just a few hints on what we're doing, new and improved PRRT. We talked before about the long circulating agents like ibidodate. There are other drugs that have an improved targeting, like the somatostatin receptor antagonist. I believe Professor Baum will talk about that. He's one of the leaders of this action. Intraarterial PRRT, we have some data that I can show. This is what we talked before. I'm not going to discuss it any further. Enhanced delivery through intraarterial administration. We have concluded a protocol where we administer 4 cycles of lutetium dotatate, 2 intraarterially and 2 intravenously. Why this? Because neuroendocrine tumors metastasize to the liver for the majority, because if we give a drug directly into the arteries of the liver, there is a preferential accumulation of the drug in the tumor, so we can give more radiation dose to those tumors. And that's what we did, and we had actually a huge volumetric reduction in our patients. These are the waterfall plots that show that apart from one patient who had a very high proliferative index, all the patients had a huge volumetric reduction. Where are we going? We're moving towards new forms of radiopharmaceutical therapy, new target and new targeting molecules. We have the standardized one like PSMA, dotatate, FAP also is becoming, coming to a high maturity phase. We have new targets and new molecules with strong clinical proof like GRPR, CXCR4, DLL3. We have early clinical signals like carbonic anhydrase, integrins, and then new early trials like GPC3, for example, in hepatocellular carcinomas. And I like to talk about DLL3 because it has relevance for neuroendocrine tumors, being this a neuroendocrine tumor specific session. DLL3 is an antigen, is a protein that is expressed by high-grade neuroendocrine malignancies, but we discovered, and it's known, that it's not just the high-grade neuroendocrine cancers like small cell lung cancer or the dedifferentiated prostate cancer, the so-called neuroendocrine prostate cancer, but also well-differentiated neuroendocrine tumors have DLL3. it is more present when the tumors are more dedifferentiated, more advanced, more active as tumors, but it's present in well-differentiated neuroendocrine tumors nonetheless. We have set up an imaging of DLL3 with a DLL3 PET with this very complicated name, but it's an anti-DLL3 antibody. And these are lesions from a neuroendocrine tumor, small cell lung cancer. And this is an adrenal metastasis. These are brain metastases. The nice thing is that, the interesting thing is that this is an approach that can be theranostic, so we can label this thing. This is the zirconium-89 for PET. We can swap the isotope and put a lutetium-177 or an actinium and do treatment to these tumors. And this is just to show you in our experience that DLL3 is expressed. This is the DLL3 PET of patients with pancreatic G3 neuroendocrine tumors. And we do have expression of the target, both when the dotatate PET is positive and also when the dotatate PET, like on the right, is negative. Finally, I just want to remind that the effect of treatments on tumors is the resulting of two opposing forces, the dose to the tumor and the radioresistance of the tumor or the normal tissue. That has to be taken into account. The dose is measured with dosimetry, and the radiosensitivity or radioresistance is something that is probably, it's not well known, but is genetically driven. We measure the dose with dosimetry, and we have to consider that both for neuroendocrine tumors and for prostate cancer, there is a dose-effect relationship. So it's not an abstract thing to wanting to do dosimetry. To measure radiosensitivity, we need to consider the genomic asset of the tumor cell. We had developed a few years ago this radiosensitivity marker, which is called PPQ. There is something that is a genomic expression asset combined with Ki-67, and it's measured at baseline, and we can define patients as progressing or responders or non-responders, and the responders are the ones who actually have a longer progression-free survival after PRRT, and the non-responders are the ones who have a shorter progression-free survival. So that's very important. And inspired upon that, we have devised a DLL3 protocol that utilizes this concept, both dosimetry and molecular signatures, and we offer therapy to those with PET-positive lesions, small cell lung cancer and neuroendocrine prostate cancer. So in conclusion, theranostics is a proven personalized approach. Use the same molecule to find and fight cancer. Two treatments are already approved. Clinical trials show significant survival benefits, and US and Europe are both leaders, but challenges remain in access, supply, and workforce. And thank you very much for your attention. I have to thank everybody who I have the pleasure to work with.
And with that, we've come to our final two speakers. The first one will be Dr. Eric Mitra, we wanted to load you up with Eric's today, who will talk to you about where we are in the US in theranostics and PRT and what's available here. And then we will move to Professor Dr. Richard Baum, who will talk about G3 tumors and beyond. So I think, are you guys switching it? I hope. Dr. Mitra is, for those of you who don't know him, is at Oregon Health Science University.
Yes.
I got all those acronyms
Yeah,
correct.
it's very hard to remember that.
Yeah.
All right, well, I just want to really thank Josh and Lisa for inviting me to be here. It's great to be here and speaking to you directly, and also for everyone online. And also, it's a great slew of speakers that they've gotten together. It's really nice to see some people that I haven't seen for a long time, so it's great to be here. My talk will basically kind of bridge between the great talk that we just heard from Lisa and then the next one we'll hear from Dr. Baum. What I'm going to focus on is really kind of where we're at in the theranostic space. Sorry. Kind of where we're at in the theranostic space in the United States, and talk about some of the ongoing trials and hopefully kind of focus on really what's going to change in the next few years. It's a really exciting time, I think, for us in the field overall. Yeah, is this the next one? Yeah. Mm-hmm. We're all so used to speaking with slides that we can't function without them. But yeah, so basically just kind of an overview of where things are and where things are headed in the sort of immediate future. And then I think Dr. Baum's talk will be a little bit more expansive for the future, even beyond that. So let's just dive right in. I'll focus both on the imaging, but mostly on the therapy. On the imaging side, this list is the currently approved radiopharmaceuticals for imaging. So you can see that we already have a decent number of them available. The first one on the list is basically no longer used, but all the other ones are PET imaging agents. And all of them are FDA approved, but the one in the middle that's, all the ones that are in yellow are not only FDA approved, but they're also commercially available. The gallium-68 DOTATOC is a new agent that is FDA approved, but not yet commercially available. However, this is, again, an example of something that's going to change, most likely this year. Later on, we'll have that availability as well. The difference between DOTATOC and DOTATATE is very, very small. It's a 1 amino acid difference between the two. So largely, it's kind of similar, but it's not entirely the same molecule. Between copper and gallium, this is a question that often comes up because different institutions will use the different agents. The bottom line is this is the same patient imaged with both of those agents. As you can see, it's essentially the same. There are a lot of technical differences between those isotopes, but more or less, the bottom line is either one works quite well, and the target DOTATATE is exactly the same for both of them. So there isn't even that difference between DOTATOC versus DOTATATE. So kind of the take home is that I think you can essentially use them more or less interchangeably. The role of FDG PET was mentioned by Dr. Fine. There is definitely an important role. Essentially, the short version is that as the grade of the tumor increases, you lose somatostatin expression and you have increased glucose utilization, which is what FDG looks at. But what this slide shows is that even in the same patient, you can have tumors which are better shown by FDG and better shown by DOTATATE. So sometimes you need to do both types of PET imaging to be able to kind of capture everything that's going on within the patient. This is a slide that is, I know you can't read it, and that's completely fine. Our group actually did a very thorough review paper not long ago. This was published in 2024, looking at just on the imaging side of new targets that are being looked at. And again, as Lisa's talk described, generally speaking, there's a huge number of different targets that are being looked at, and this is just one example of that, where there's just so many different things that are being looked at, both from the target as well as from the isotope. So again, in the future, I think there's many more things coming down the pipeline other than the more basic ones that I showed you. Okay, so let's shift our focus to the therapy side, so PRRT, or peptide receptor radionuclide therapy. As was described by Lisa, we currently only have this one agent that's available, which is lutetium-177 DOTATATE, given at a pretty fixed dose of 200 millicuries that's given through the vein for up 4 cycles, and it's typically used up until the NETTER-2 trial. More recently, it's used as a second-line agent. And in the future, the exciting part of this field is that every single aspect of this treatment is under research evaluation and is probably going to change in the coming years for the better. This is how, extensive all of these changes are. Even the indication of doing it for well-differentiated grade 1 and 2 neuroendocrine tumors actually has already changed. So let's give you some examples of where things are going. So Lisa mentioned this briefly about the different NETTER trials. There's the NETTER 1, which led to the approval initially in 2018 of lutetium dotatate, and that was done in the grade 1 and 2 patients, and it was really only for well-differentiated midgut neuroendocrine tumors, but actually the approval subsequently was for all gastroenteropancreatic neuroendocrine tumors, thankfully. The NETTER 2 trial was published much more recently, and the big difference there was that it advanced it to higher grade tumors, so grade 2 and grade 3. Also, big change was that it was first-line treatment rather than waiting as a second-line treatment, so that was a big change. And also, it specifically also included pancreatic neuroendocrine tumors, not just the midgut tumors. So it was quite an evolution of the use of lutetium dotatate, and that led to a label change, so that now we can have the option of using lutetium dotatate as first line as part of the label rather than using it as a second line. And in fact, there's even another trial now going on, NETTER 3. NETTER 3 is now kind of, in a sense, combining NETTER 1 and NETTER 2, in that it's looking again at the grade 1 and 2 population, but using it as first line rather than as second line. So that trial is actively recruiting right now, and we won't really have the results of that for a few years, most likely. So this is just an example of kind of the evolution of the utilization of lutetium dotatate in the different categories of gastroenteropancreatic neuroendocrine tumors. The next thing that I want to mention that's changing again this year is what are called radioequivalents. It's a rather confusing term. I guess more basic way to think about it is as a generic, but that's not the proper term, apparently, for radiopharmaceuticals. So it's called radioequivalents, and both of this was announced recently. That both Lantheus and Curium have these radioequivalents, which have sort of received tentative approval, and they're expected to receive final approval in the coming months, actually. It's also held up by some ongoing litigation, which is public news with Novartis. And so once all of those things are settled, the expectation is that these will also be launched commercially later this year. And so this is going to be, quite an interesting time, where we went from this one product that's available, the lutetium dotatate, to actually 3 different versions of essentially the same compound. Ultimately, I think this is good for patients and for providers, because choice is always good. But the kind of take home again is that these are essentially the same molecule. The next level change from that is, we talked about the DOTA-TOC in terms of the imaging isotope, but also it is also being looked at as a therapeutic isotope. So this is the lutetium 177 DOTA-TOX. This is owned by a company called ITM. The generic name is etotirottide, and they already have a brand name, because again, they too are anticipating a launch later this year as well. So this is really getting suddenly quite congested in this space, called Raytherity. This was based on the COMPETE trial design, which has been published already, and what you can see there is that it looked at this etotirottide or DOTA-TOC compound 4 cycles, similar to lutetium dotatate. However, the difference you can see there, if you look closely, is that it's given every 3 months rather than every 2 months. So that's one difference between them. And also the comparator arm is also importantly different. It was to everolimus rather than to a high-dose octreotide. And it included patients that were treatment naive as first line, or they had progressed on another line of treatment as well. And it was, again, for grade 1 and grade 2 patients. So that study did meet its primary endpoint. And again, it is expected to be launched in the coming few months as well. So once all of these are available, suddenly we'll have 4 agents in this space rather than just 1. And it's all due to happen this year. And this also does have the imaging isotope as well, so the gallium DOTA-TOC will also be available in addition to the lutetium DOTA-TOC. Just want to mention real quickly that ITM also has an ongoing trial called the COMPOSE trial. So this is furthering that same treatment, but now for grade 2 and grade 3, similar to what NETTER-2 had done. And so the comparator arm similarly is kind of more broad for what would be appropriate for that type of patient. This has not completely concluded, and so we won't see the results of this for a little while. Okay, it was mentioned by Lisa that we're also looking at differences in radioisotopes. And so here's kind of a little summary of some of the more common radioisotopes that are used. Traditionally, we use beta minus isotopes, such as yttrium-90, which was mentioned by Dr. Fine for the liver-directed therapies. And then the only one that's available commercially, again, is the lutetium-177, which we've talked about extensively. Now, in the future, there's going to be several different versions available, including alpha isotopes, such as actinium-225 and lead-212, and then also terbium-161, which in addition to beta minus also gives off this thing called Auger electrons, which have sort of a different path length than beta minus. And so the concept is that the combination of this type of radiation can lead to better efficacy potentially in patients rather than just using the beta minus agents such as lutetium. So first, what is alpha? So it's a bit of a physics topic for sure, but in the middle you see this radioactive isotope in blue, and it's giving off different types of radiation. So the beta positive particles are actually what we use for PET imaging. They ultimately give off high energy gamma rays, and gamma rays, as you can see in the bottom, just pass through the body, so they don't interact with the body. They can't be used for therapy purposes, but they allow us to take pictures. So that's the gamma part of it. Then beta minus, as you can see there, we've been talking about it pretty extensively with the lutetium. That is our sort of therapy workhorse up until this point. And then alpha, the big difference is essentially the size. So in terms of atomic mass, which is hard to grasp, but it's 8,000 times the atomic mass of a beta particle. So what that will result in, when you look at the DNA damage on the right-hand side, is much more destruction of the DNA, and so therefore of the cell growth, rather than the beta minus particles, which are typically causing single-stranded DNA breaks versus double-stranded DNA breaks. In terms of the path length on the bottom, you can also see that within human tissue, because of that much larger size of alpha particles, they'll travel much smaller distance in tissue, as opposed to the beta particles, which will travel a little bit farther. That too is, at least in theory, thought to have a benefit, because it'll really be restricted to the cancer cells it is targeted to and not affect some of the surrounding normal tissue, and so therefore some of the toxicity might be a little bit less. Of course, all of this is ultimately going to be seen in clinical trials. There's 3 clinical trials that are ongoing for alpha PRT at the bottom, and when this slide was put together a little while ago, things have advanced now, so that some of them are actually increased to phase 2 and phase 3 at this point. And then one of them, the middle one, the lead-212 dotamtate, that one is actually on hold for the moment. Hopefully it'll resume again in the future. But the one that's progressed the furthest so far is the one on the bottom. That's the actinium-225 dotatate trial. That one has completed recruitment at this point, actually. But of course, these trials take time for the follow-up period. So they're expecting to have an interim analysis hopefully later this year. But then the final analysis won't be for quite a while after that. However, that's expected. Hopefully, if everything pans out, then that would be most likely the first alpha dotatate molecule that will be FDA approved. And then the lead-212 VMT AlphaNet on the top, that's in phase 2 right now, but is kind of gearing up for phase 3 trials as well. So far, the preliminary data that we have with alpha therapies, and specifically with in the NET space, because it's also being looked at in the prostate space as well, is some of it is very compelling results. This is an example of a patient who had progressed previously on beta therapies and then was switched to alpha therapies, and you can see there's a reduction there significantly. But I will also say that there have been some toxicity signals too that are there. and have been reported. So, I mean, I think it's ultimately, we need to have the phase 3 results really come out and really see in a large group of patients, you know, what the effect is. But certainly very promising. The theory behind it hopefully now kind of makes more sense to you, why it's creating so much excitement, and the trials are ongoing. The terbium, this is just one quick example. Dr. Baum probably has a lot more experience with this because in the US this isn't looked at too much, but again, this is the sort of combination of beta minus and Auger. And this is just an example of looking at that in a neuroendocrine patient. And then the last thing that I wanted to, or last couple of things that I wanted to mention in the last few minutes is, again, we are sort of fixed using 200 millicuries at this point. The only time we make any adjustment to that clinically right now is actually for toxicity reasons, if because of your labs or some other reason, potentially your symptoms. If we need to, then we can reduce that to 100 millicuries, and then we either stop if that didn't work, or if it helped your symptoms and labs, then we will go back to 200 millicuries. So it's really quite limited. You know, we don't really adjust things that much. In the future, though, I think that we will have much more variation in this. So Dr. Lin talked about the dosimetry aspect of it. We too at our institution do dosimetry, especially for patients who are being retreated with Lutathera at this point. So I think that there's potentially in the future, once some of those trials are done, we'll be able to modulate the dose a little bit more specifically for patients. The problem right now with the dosimetry, as you probably gathered from his talk, that is very complicated to do, and there's no clear protocols on how to do it and so forth. So this is definitely an evolving area, but I do feel like it'll be done. In the retreatment setting, right now, again, there's a lot of confusion. You know, once you've had the initial 4 cycles, and if you are getting additional cycles, should you just do 2 cycles more, or should you do 4 cycles more? This is why, again, we do dosimetry to try to give some understanding of what your specific limit should be. So that's something to do. And I think it's going to get even more confusing once the alpha therapies are out as well, because now you have prior potentially beta therapy, and now you're switching to an alpha therapy, which has sort of a different dosimetry profile. So a lot of excitement there, but also a lot of things to learn about how best to kind of use one thing versus the other. And lastly is in terms of combination therapies, there's a lot of ongoing trials in this space as well. If one type of therapy works so well and another type of therapy works so well, basically why not combine the two to have a beneficial effect between the two? So a couple of ones that I've mentioned here, capecitabine kind of radiosensitizes tumors, and so if you use that plus PRRT, then potentially you can have a more better therapeutic benefit from that. And PARP inhibitors block the DNA repair mechanism. So if you're causing DNA damage with our radiation, and then you further block the DNA repair mechanism, obviously that makes sense as far as potential benefit. Of course, and even liver-directed therapies and external beam therapies, people are looking at combinations. But the downside to combination therapies, as you also might imagine, is that each type of therapy has its own side effect profile and causes some toxicity. So similarly, just like the efficacy can be combined, potentially the toxicity could also be combined, which is certainly not what anyone wants. So that's where these trials are going to be important to see what actually works, but without causing too much harm. Okay, so in summary, again, lutetium dotatate in the US was FDA approved in 2018. Now, more than 200 centers are providing this PRRT. There have been these multiple publications, including NETTER-1 and NETTER-2 at this point, and we always, do everything in the context, hopefully, of a multidisciplinary tumor board. So, although in a sense this has become sort of routine, and again, many of you have probably already had PRRT at some point. Why I think this is such an exciting time in the field is hopefully, as I've shown you, every single aspect of the current way we perform PRRT is being looked at in trials. And particularly this coming year, I think there's going to be a lot of new availability of different radiopharmaceuticals. And in the coming years, again, there'll be a lot of availability of new things, including these alpha therapies. So with that, I will conclude. Thank you so much.
So last but not least, we talked about it's going to be an exciting time and exciting years. What is next? Where do we talk about G3s and what the future holds? And with that, I don't know. Let's see. Where's the presentation? Are you doing the presentation there? Okay. Professor Richard Baum has come from Germany. He reminds me that it's about 2 in the morning there. So, yeah? 2 plus or minus? Yeah. And I had the fortunate experience of meeting him in 2008 in Toronto. Yeah, in Toronto at a patient education conference that was held by CNETS Canada. And we've become very close friends since that point. And his ability to, I don't want to say predict the future, but look to see what's coming next is somewhat legendary at this point. So without further ado, it's not on this screen, but it's down here. I will turn this over to Dr. Richard Baum, or Professor Dr. Richard Baum. You're there.
Thank you, Josh, for giving me the most difficult task today, namely to speak about G3 neuroendocrine tumors. And some 10 years ago or so, I should have finished now because there was nothing in the area of radioligand therapy 10 years ago. These are my disclosures. I have no conflict of interest except that I'm still very much in love with radiolabeled molecules. And I want to dedicate this lecture to one of my patients who came around the time, Josh, you came, and at that time he had one boy who is the right one, and unfortunately he died some weeks ago with 5 sons, a very happy family, and nearly 20 years of what you heard is the most important. Good quality of life, good family life, doing a lot of sports in all different areas, and he did not even die from his cancer, but from an infection. So, 10 years anniversary, gallium DOTA-TOC was approved in 2016, first in France, then in Austria, and then in Germany. 8 years ago, FDA approved DOTATATE. And you have heard about these different trials, NETA-1, NETA-2, NETA-3. I will only concentrate in the aspects of G3 tumors here. NETA-1 did not deal with G3. As I said, it was only well-differentiated G1, G2, slowly growing tumors. NETA-2 did, and in a very successful way, as you can see here. It was higher grade 2 and also G3 tumors, and there was actually a very good advantage of using radiolabeled peptides for treatment of G3 when you compared it solely to cold sandostatin concerning mainly the progression-free survival. So the time you can enjoy life, right? The time tumors are not progressing. And the NETA-3 you heard is again only in G1, G2 tumors with a high tumor load, but primary treatment. You also heard COMPETE, and I was a principal investigator in Germany of this trial, which showed for the first time that median progression-free survival was significantly longer with non-carrier added lutetium DOTA-TOC versus everolimus. And I think this will become very important also in the aspect of quality of life. What is a better quality of life? So upcoming developments, alpha radioligand therapy, I call it ART, with actinium and lead-212. And I think one also has to mention the end agonist, specifically in G3 neuroendocrine tumors, like JR11 or LM3, or what we have developed, LM4 data. Also, Auger emitters, I will not talk about this, combination therapies and novel targets. Thanks to Lisa, you heard about DLL3, which might play an important role in G3 neuroendocrine tumors. Now, the betas have a tissue range of about 12 millimeter maximum, low energy when hitting the cancer cell, and therefore making mostly what we call SSB, single-strand breaks of DNA, and best fit in bulky tumors. And the alpha emitters, which I'm personally using since 2016, so for 10 years now, have a very short tissue range. You see the scale here comparing 100 micrometer for the alphas, and for yttrium-90, the 12 millimeter, which are many thousand of cells. And you also heard about the ongoing trials. What interested me specifically was combining the antagonists, which have a better binding on the tumor cells because there are more keyholes where our peptides are fitting in, as you can see here, by staining using an agonist or an antagonist. And also, if you just look at the images in the same patient comparing DOTA-TOC or DOTA-TATE, which are very similar actually from the imaging aspects, and the antagonist, you see there is much higher uptake in the tumor. And you can, because of the low uptake in the liver, you can even detect very small lesions in the liver and also in the bones. So we have many patients where repeatedly CT scan, MRIs, and so were done without any detection of bone metastases, but many lesions seen on gallium antagonist imaging, for example, LM4 or others. And then we used for the first time some years ago the LM3, which is a very interesting antagonist because it can be labeled with gallium, with lutetium, actinium, yttrium, and many other radioisotopes of interest for therapy. And what we had seen is that patients with a very low uptake in their tumors, or even any uptake in their tumors with DOTA-TATE, have a very high uptake with the antagonists. So antagonists are completely different from the imaging, but also for the treatment. And for G3-NET, the so-called WHO classification changed around 10 years ago, because until then, as I said, G3 were only one group of tumors, right? They were considered all the same, high-grade, aggressive, chemotherapy only. And then there were a new group of tumors, and this is valid today, the well-differentiated NET G3, which have a relatively fast proliferation, so many cells divide within a given time, and they are often somatostatin receptor positive, specifically with the antagonists, and biologically they are closer to the G2 tumors. And then we still have the poorly differentiated, and you heard already today the difference between the well and the poorly differentiated by George Fisher, who explained it very nicely, which still are not suitable because they do not have or do express very low amounts of somatostatin receptors. So I just want to show one patient, and George, you remember certainly this patient very well, who had a grade 3 tumor with a high proliferation of over 50%. And he was operated with a tumor of the pancreas with a Whipple, like you had, the same. And then received CAPTEM chemotherapy because it was already metastatic from the very beginning, liver segmental resection, and then 4 cycles of PRT and transarterial chemoembolization. And then there was a local recurrence and so on and so on. If one counts the number of treatments, overall there were 7 different treatment cycles before the patient came. And on the left you see the copper 64 dotatate PET in this patient with still a lot of liver metastases, but also extrahepatic disease. And just a few months later, the same patient with the end agonist. And you see there are many, many more lesions seen in the liver, and also the extrahepatic lesions are more clearly seen with less background. So this shows that these end agonists just have a definite advantage in this patient if it comes to another treatment. And if I ask George, what would be your prognosis for this patient? You know, everybody agrees that there might be less than a year or so overall after all these treatments. But nevertheless, we started just with lutetium, and you see the really very impressive response in this patient. After 3 cycles from the 100 metastases or so in the liver, there was just 1 lesion left. And then, actually, it was again George and his team which came in and gave additional treatment, and the patient was doing always very well, physically well, and clinically well. And despite this, there was progression in the liver with new metastases coming up. And then we decided not only to do lutetium, but a tandem treatment combining actinium and lutetium. So tandem means that like 2 people on the bike, you have 2 radioisotopes hammering on the tumor, right? The beta and the alpha emitter. And we asked again the surgeon to do his job, and he resected the metastases in segment 4. And the result was that there was a complete remission of all these metastases after all these years, which was really amazing. And how can we achieve these good results? One need to be persistent. So even if the situation looks desperate, one still have to find, in collaboration with your colleagues, you know, the best weapon to fight the tumor. And we should think of combining treatments. That is the future of PRT, is combining it with immunotherapy, with other targeted treatments. And don't forget the surgeon. The surgeon is not only important in the very beginning of a disease, if you heard from Eric Liu, take it out, take it out, take it out, is really important. But also at a later stage, you can ask the surgeon again. And you see the patient here who was winning after all these treatments, the pickleball with his wife. And the story goes on, but I have to stop here, otherwise I will be there in 1 hour. So we systematically studied, you know, the use of actinium and lutetium tandem treatment with the antagonists, and we are presenting the data here at the meeting, so I can rapidly go through the slide just to say that these patients had a lot of treatments before. This is how we are doing it in practice. So there is a pre-medication with some cortisone and an antiemetic. We do kidney protection now, not with amino acids anymore, but with para-aminohippuric acid, which is much better tolerated and goes within a short time. Then we don't do these long infusions over half an hour. We just inject over 10 or 15 minutes, and then we do SPECT-CT on the next day. So it's very convenient for the patient. And you see that the patients we treated had all previous heavy treatment. 100% had sandostatin, 90% beta-lutetium or yttrium, and chemotherapy 95%, surgery more than 2/3 of the patients, and so on and so on. And we administered nearly 50 cycles of actinium. As you can see here, monotherapies, but also tandem treatments. We saw some acute effects, especially in those patients getting high doses or dosages, to be correct, with some nausea, emesis, flare pain, and diarrhea, but all were self-limiting, and the patient could leave the hospital 48 hours after the injection. Concerning toxicity to bone marrow, to your blood counts, we have seen no G4 cases and only one case of acute myeloid leukemia, but this patient had been treated with yttrium 90 already 12 years before, and that might be a late sequelae. Also, nephrotoxicity was not present in any of the cases. Actually, many patients improved in kidney function and survival. So 56% of the patients are still alive after a follow-up of 35 months, which is amazing if you look at G3 tumors, right? Not the usual G1, G2. And the efficacy, if we look at the molecular imaging with PET, we saw also quite impressive results. An image tells you more than numbers. This is a lady actually from Denmark, and she was coming in a wheelchair after overall 8 cycles of lutetium dotatate in Sweden, and could not walk anymore with a very large liver. And after one tandem treatment, she regained a lot of the quality of her life, and we did a second tandem treatment, and the liver get much smaller. This is really impressive results, but not only from the images, but mainly from the well-being of the patient. She could start swimming again and bicycling, and the same is true for this colleague, a doctor from Sudan, who received first Lutathera treatment, did not respond, had progression in the bone, and then with lutetium and later on with a tandem treatment, he recovered very well. So I think one can state that radioligand therapy works in G3 neuroendocrine tumors. Every patient should be intensely discussed in the multidisciplinary tumor board, and then you have to choose the best weapon for the patient. If you look at the median PFS in the subgroup I presented, the results are much better for radiopeptide treatment than for cold sandostatin, which is not astonishing actually. And our experience, you see that we have treated 35 patients with 57 actinium cycles, and the longest survival was more than 2.5 years actually. So how do we choose the right patient and what is coming next? I think FDG PET, the glucose PET you heard about, is very important to give you information if all the lesions you are seeing have receptors, can be really treated with radiopeptide therapy. And then you have to match the therapy to the biology, looking at the right peptide, agonist or antagonist, and looking at the radioisotope, either lutetium alone or a combination, the tandem treatment, or in future also other alpha emitters, for example, like lead-212 or astatine, which for me is also very, very promising. So I have to thank many people around the world, specifically in the neuroendocrine tumor areas. And if you as patients are interested in some of these topics, there is a virtual summit from the International Centers of Precision Oncology, the ICPO, which takes place actually in November. And you can scan the code and log in. I think for patients, you will get free access if you need. And I would like to invite you all to the 9th Theranostics World Congress, which will take place in Japan in March next year. And I would like to finish with, for me, most amazing lady in our field, which is Marie Curie. And she received, as you know, 2 Nobel Prizes in 2 different specialties, in chemistry actually and in physics. Nobody else has ever achieved this, but the Academy of Science in France did not accept her as a member because she was a woman, right? Nowadays they would offer her definitely more than 1 seat. And she said something which is very, very encouraging. Nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. And you can also read it in Polish if you know Polish. And I think it is for the future of science and for the benefit of our patients. And I hope that I gave you some more information, so you need not to be feared, but you can be positive and enjoy your life. Thank you very much. Okay. At 2 in the night, yeah?
What? At 2 in the night. Not a couch, a seat. Dr. Mitra, Lisa, we're not going to have a very long Q&A session because we have a reception that is starting shortly, and we need to get over there in 15 minutes. And there's some microphones coming. George, I want to ask you one thing that came in over, we get one of these questions almost all the time, or not. We often get this question with surgery, but we get it with biopsies or anything where something happens is having a biopsy or surgery spread the tumor around. And this one was a question on, does having a biopsy spread the tumor? Because we were talking about that earlier. I would take a crack at it, but you have an MD and I don't. And then let's pass some of these around. If any, they're just running to do that and set those things up.
We have technical. Can
Yeah,
you hear me?
you're good.
Okay. So I get asked that a lot. It's a common question. And there certainly have been cases, especially intraperitoneal tumors, where you biopsy and there's a little growth of a tumor nodule at the skin. But many times people are asking about that when tumors have already spread and we're getting biopsy of metastasis, which the chance of seeding from that is so low, and the important information you get. Nowadays we're getting information about the genes, and we're finding drugs to treat the genes for some cancers. Not as much neuroendocrine, but hopefully someday. What did you want to do? I think that if your doctor recommends a biopsy, you should always ask, why do I need the biopsy? And if the information that he gives you or she gives you is important enough to warrant the biopsy, I guarantee you that that's the valuable thing to do, and risk of spreading the cancer with a biopsy is really exceedingly low. I can't say it's zero, but it's exceedingly low.
Dr. Baum,
Maybe the interventional radiologist can tell us something about the needles which are used today, right? Which is actually a closed system, so you don't lose any tumor cells when you are retracting the needle from the tumor.
So it's kind of what Dr. Baum was mentioning is oftentimes when you're trying to localize a biopsy and just have it there are actually systems for some of the devices where you can actually basically cook the track. So outside of the source where you're biopsying it, hopefully you're going to cook that track, which will reduce the risk. Now, not all biopsies do that, but kind of what George was mentioning in its own way, oftentimes there's widespread metastatic disease. Each circumstance, you do want to know why you're getting the biopsy, what will these, what sort of information are you trying to gain from it, but we're always weighing the benefits and the risks. And sometimes that information is so important that we're going to try our best to not seed, to not have that happen. But if we need that information to help guide your care, we're having to weigh the benefits and the risks for each piece, and we'll do everything we can to try and minimize that risk. And there are some
Lisa, I know you want to
tools.
jump in.
Oh, go ahead.
When you
Absolutely.
finish.
No, absolutely.
Just wanted to actually reinforce what is being said. I think we should not waste the opportunity to characterize the tumors. The tumors evolve, they are different in different lesions. And for example, situations like your therapies, your interventional therapies are beautiful opportunities to biopsy the tumor. You're accessing the vessels, you're accessing the lesion. Why not take a little piece? That's what we do, for example, at Memorial. Our patients have characterizations, and we see this shift from G1, G2, G3 very frequently. A lot of the patients, for example, where I come from in Europe, they have the characterization that they have at the beginning, maybe pertains to 10 years ago, sometimes even 30 years ago. And so these patients are characterized as G2 tumors, and then we do an FDG PET and we see that the lesions are all positive, and then that triggers a biopsy, and we notice that, oh my gosh, it has different, all of a sudden it's a G3 tumor. Maybe it's a continuum process, and taking the advantage of procedures may help us gaining more information.
So one of the questions, and we'll get you a microphone real quick, there should be one, but one of the questions I want the panel to address, or Dr. Baum or Lisa is, or Dr. Bodai, switch going back and forth. Professor Baum, Dr. Bodai.
Just say Richard. Right?
Richard, we're all good. While the majority of us express somatostatin receptors, there are a set of us who don't express receptors. And what do we see coming, whether it's an FAP protein or other types of things that we can do to